Okay, so we are live in 3, 2, 1. Ma'am, please start. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on recent advances in breast and lung cancer. And for this, with immense pleasure, I would like to welcome Dr. Srinivas KG, who is Consultant Medical Oncologist, Bharat Hospital and Institute of Oncology, Mysore, for the welcome and introductory note and to carry out the further proceedings. Over to you, sir.
Thank you. Good evening, everyone. I welcome all the delegates, teachers, friends for this meeting. I look forward for a very positive and successful scientific symposium today, and we all get educated with this scientific symposium. I welcome you all. I would like to invite Dr. Imran, who is an oncopathologist from Continental Hospital, to start his proceedings.
Thank you very much, Dr. Srinivas, for giving me this good opportunity. So the two abstracts, am I audible as well as my screen visible?
You're audible, sir. You need to share your screen.
I will share my screen. Now
Yes, sir. Yes, sir. It is visible. Just make it a full screen.
Full screen. Yeah, thank you once again, Dr. Srinivas, for giving me this opportunity. The two abstracts I'm going to present now are the ones which were presented at ASCO this year. The first abstracts, the title is, both are from I-SPY2 trial, and the title is Pathologic Complete Response Rates for hormone receptor positive and HER2 negative breast cancers by molecular subtype. A brief introduction about I-SPY2 in this setting is they used molecular data sets or subtypes in breast cancers to predict the tumor response, and their clinical endpoint was pathologic complete response in a neoadjuvant setting. And as you know, pathologic complete responses can be defined and determined only on histopathological examination of a resected specimen post neoadjuvant, where under microscope, when the entire tumor bed and the involved lymph nodes are sampled, should not be able. There should not be any viable tumor cells. So that's called complete pathological response. Or pathologic complete response. And if the microscope, if few cells are seen, then it becomes a partial tumor response, and those cases were excluded from this study. In spite of having good hormone or the receptor status classification, but still the hormone receptor, this subset, that is hormone receptor positive and HER2 negative breast cancers, is a heterogeneous disease. So, and on neoadjuvant, there are one subset shows very low PCR rates. So the question asked in this study was, how can we utilize clinical and molecular characteristics to better classify this subset in an early stage, that is stage 2 and stage 3, and to select the best therapeutic strategies. So I-SPY2 trial, as we discussed, it was an adaptive multicenter phase 2 clinical trial, prospective, of neoadjuvant therapy for patients with early breast cancers, with a primary endpoint of pathologic complete response. And here a lot of analysis was done with the breast cancers of the patients recruited using only molecular profiling. I say the eligibility criteria was uh, uh, tumor size of greater or equal to 2.5 centimeters, stage 2 or stage 3. And mammo print was also taken with the subtype or the high score types. The low scores were excluded. And as usual, the control arm was the chemotherapy, the routine standard chemotherapy arm. But in adaptive randomization, the specialty of I-SPY trial was a multiple drugs could be tried based upon different molecular pathways of a particular tumor type. So mostly this included uh, uh, drugs which targeted the activating molecular pathways. So then followed by the standard doxorubicin, and then the surgery. And for surgery, the primary endpoint uh, of the study was PCR. So it should be YPT2 or even if DCIS was present and no invasive tumor is seen, that it was considered as pathological complete response by definition. And nodal should be completely negative for any residual tumor. So these are the drugs which were tried, which were are the investigational drugs, mostly small molecules like pathway inhibitors and chemotherapy, and importantly there was checkpoint inhibitor, pembro, in one of the investigational arms. So to get rid of this. So this slide shows various molecular subsets which were compared, like the mammoprint high and then blueprint basal and luminal subtypes, and more importantly, the response predictive subtype in that immune signature subtypes. And this response predictive subtypes was derived using multi-omic platforms, using immune signatures, DNA repair signatures, and basal luminal markers, and our usual receptor markers. So this is the demographic data of all those 379 patients that fell into this category of hormone receptor and HER2 negative, and well represented by all races, and then stage 1 and 2, and different both common and uncommon histological types, and the various combinations of hormone receptor status. So this slide shows the observed PCR rates. When you take only the hormone receptor status, you could see most of the drugs performed almost same as to the control arm, chemotherapy arm, and there's a little improvement in the pembro. And when you take the response PCR rates with only the histology and the stage, the performance was very poor. The PCR rates were almost very were not at all predictive. So, and then this slide shows the difference in mammoprint subtypes and the blueprint subtypes. They're almost, almost equal in number, 29 and 28% of this subset. That is basal and MP2. And this chart shows how when you cross match, there is amount of mismatch, and like MP high, about 10% fell into the basal category when you take blueprint subtypes, and MP high, about 20% went into the luminal subtypes. So these 20, if it had taken only MP as the high as the criteria for starting your therapy, this 20% would not have responded to the investigational therapies. And however, MP high 1, about 10% fell into basal, and this subset really responded to the investigational therapies. So now this is a comparison between the basal and the luminal. So now if you take basal, the blueprint subtypes taken to the study was basal and the luminal. There is a clear separation. When you take this molecular subtypes, there is a very clear separation in the response rate, that is PCR. Good number of patients gave a PCR rate of very high PCR rate, but look at the luminal subtype, it's comparatively very less. And similar, there was a clear separation between MP high 2 and MP high 1. So response predictive subtypes, which is the important criteria in the study, was derived using protein phosphoprotein gene expression clinical data and classified under these categories. HER2 negative immune was the one which was which showed the best performance. And if you take only the receptor subtypes, so there is a gross mismatch. So many hormone receptor positive cases were actually misclassified. Actually showed HER2 negative immune phenotypes. And here one RPS signature, that is HER2 group, was the immune positive signature, which incorporates changes in immune cell gene expression and chemokine levels. So, and RPS score was developed to identify treatment subtype pairs that maximized PCR rate. So now coming to the critical slide, here the RPS, if you see the immune positive score and the immune negative score in our RPS, the immune positive ones were the one that patients that benefited with the PCRs in most of the treatment arms. These are like the Pembro showed the best PCR rate of 69%, but similarly Pembro showed only 4%. In the immune negative subtypes, and also this slide highlights the fact that the blueprint or the RPS score fared superior to the blueprint subtypes of basal and luminal. So the conclusion was they suggested that mammoprint high and blueprint basal signatures were associated with high PCR rates in patients with high risk early hormone receptor and HER2 negative breast cancer therapy. And the RPS immune positive signature was associated with a higher PCR rate in patients with this subset, especially with Pembro arm, 69% PCR rates. So the final conclusion was this subset of breast cancers is a heterogeneous disease. And the use of clinical and molecular biomarkers may be able to identify a subset of patients that is more likely to derive benefit from neoadjuvant chemotherapy and immunotherapy like Pembro. So this was the conclusion of my first abstract. I have to go to the next abstract. Hello? Hello?
Oh, yes, sir.
Did it end well? Like all the slides were visible and
yes, sir.
Audio also is good?
Yes,
so
sir.
I should go to my next. I'll close this. Okay. Is it visible?
Yes, sir.
Yeah, this also this study or abstract also showed this. It also belongs to the same trial, but in a different subset. which HER2 positive and hormone receptor negative. And the endpoint here also was complete pathological response and presented by Alexander Thomas. So in the background, HER2 positive breast cancer is a highly heterogeneous disease. It was never like HER2 enriched like we used to believe before. There are also luminal HER2 rich, then basal HER2 rich. So it's a highly heterogeneous, and that's the reason that there is a different response rate for trastuzumab and chemo arm in different HER2 new positive patients. So it's really not truly predictive in today's times, the HER2 enriched or the HER2 positive tumors. So they hypothesized that molecular subtypes may predict the disease response to investigational agents more than the current hormone receptor status only. The receptor status only. So and they reported that the PCR rates in the first 6 agents in this trial, and they considered hormone receptor, the receptor status, and again the same RPS score, but here they consider HER2 luminal and HER2 or basal, 2 other molecular subtypes, not the basal and luminal of the previous study. And a mammoprint again, high risk and ultra high risk, which taken into the study. And the control arm was paclitaxel, trastuzumab, anthracycline as usual. And the experimental was a multiple drugs or investigational drugs were tried simultaneously based on the molecular subtype of the tumor, and then the resection followed by of the tumor followed by pathological examination, and PCR was the primary endpoint. So this chart shows there is improved improvement in PCR rates in various HER2 new subtypes, which is HER2 positive subtypes. So better in purely enriched compared to hormone receptor and HER2 positive. So in response predictive subtypes, so this is the mismatch that happens if the tumors are molecularly profiled using this system, RPS system. Almost this category almost 76 or significant portion is gone into the HER2 basal. So this is the subtype to be watched for in this particular abstract. So and look at this. As I said, this is the one to be watched for. In this, the PCR rates, the outcome rates were excellent, and many of the investigational drugs showed very good PCR rates, and but the luminal was very dismal. The investigational drugs failed to show the complete PCR rates, except for one investigational drug which target the AKT pathway, showed good response. So this could be the drug in future for HER2 luminal subset in the RPS scoring.
Apologies to intervene, sir. Kindly conclude your talk in next 2 minutes. Thank you.
Last but one slide, I think. So so based on MammoPrint also, it did show some significant difference in the response or PCR rates with MammoPrint ultra high. With the conclusions were the PCR rate for patients with HER2 positive breast cancer treated with investigational agents, particularly the dual HER2 blockade, were promising. Here, the dual HER2 was pertuzumab. Using the word Pembro, I think, pertuzumab and trastuzumab. Then molecular response subtypes classification provides insight on how to better target therapy. This was clearly shown in this PCR response rate. And this luminal group had low PCR rates with dual HER2 blockade, but have a high PCR rates with addition of AKT inhibitor. So this study has identified a new subgroups for AKT inhibitor to be the drug of choice in a neoadjuvant setting. And testing of AKT pathway inhibition offers a novel approach in this luminal subtype. And dual HER2 blockade with the trans2 and pertuzumab has a partial PCR rate only in MP high 2 tumors. So, but a very good response in HER2 basal, HER2 positive basal tumors of RPS subtype. This finishes both the abstracts. Thank you so much for patient listening.
Thank you, sir. You need to share your screen. Stop sharing your screen.
Thanks, Imran, for that wonderful session. Now I welcome Dr. Suresh Babu. He's a professor in Kidwai Memorial Institute of Oncology. Welcome, sir. Dr. Suresh Babu, sir.
Yeah, I think I'll start my time. I can't share my screen. I think Imran, you have stopped screening.
I stopped, Suresh.
So you can now. You can share.
Yeah. Can you see the slides now?
Yes,
Hello?
sir. Yes.
Yeah. Thank you. Thank you, Srinivas, and thank you, AstraZeneca, for giving me the opportunity. In this talk, I'll just going to talk about importance of genetic testing and other risk stratification in early breast cancer, how they are going to be helpful to us, and we are also going to look into what are the options we do have to do risk stratification of breast cancer. So the majority of the breast cancers are HER2 negative. We know that they are diagnosed in early stage. This is the more data of the world rather than looking at the data of India. If you see the world data, the 64% of the breast cancer are diagnosed in early stage, and 27% are regional, and 6% are the metastatic. But if you come to the data within our country, most of our cases are diagnosed in the local region. You can see almost 60% are locally advanced breast cancer. Metastatic are there, and the localized are almost 30%. But if you go into a data of in a regional cancer center or a center which caters more for the rural population, the early or localized breast cancer data is going to be much more lower. Other very important thing in our country is the most of our cancers are triple negative. At least we have a triple negative breast cancer more than what the Western people do report. That may be the reason why we do have patients presenting with more advanced stage, and genetically the Indian breast cancer patient looks to be a little bit more aggressive compared to the Western population. This is the Angelina Jolie effect, which we all know. The Angelina Jolie, very famous Hollywood actress, when she was diagnosed to have BRCA, she underwent a prophylactic mastectomy, which created an impact in the public. So almost there were about 40 publications regarding this. Because of it, there were people who were doing extra in BRCA testing. There was a curiosity among the public to do BRCA testing. BRCA testing, selfly doing in the public has increased, and also the number of bilateral mastectomies for a patient with BRCA positive also started increasing. So it is called remarkably as an Angelina Jolie effect. So all breast cancers are not same. We do have a very diversity in the breast cancer, triple negative, hormone receptor positive, and HER2 positive, hormone receptor negative. We know that traditionally triple negative breast cancers do behave very aggressively compared to that of the other breast cancers. BRCA is more commonly seen in the triple negative breast cancer compared to other breast cancers. Approximately, due to various literature evidence, about 5 to 32%, 35%. This is the range where BRCA positive patients are seen in the world today. Our India have literature evidence of about 15 to 20% people being presenting with breast cancer with BRCA positive. These are some of the publications which are there. One is from northern part of India, other one is the southern part of India. In southern part of India, they found that in the triple negative breast cancer patients, about 13.6 patients had their BRCA positivity. In other North India, it was almost about 18.64 patients. So the thing is that most probably why we were underdiagnosing the BRCA positive breast cancers, where the criteria to test for BRCA positivity were a little bit more relaxed previously compared to that what we have for the BRCA testing today. So why we should know BRCA positive breast cancer is traditionally patients with BRCA positive breast cancer going to be younger. They will have very high grade tumor. They are more likely to present with CNS metastasis, and they are more likely to develop relapse of the disease, or they are more likely to develop contralateral breast cancer. So traditionally, the BRCA positive breast cancers are highly aggressive, seen in younger patients who are also more prone to develop contralateral and ipsilateral breast cancer recurrence. So these are the criteria to do BRCA testing. NCCN came up with a much broader line to do BRCA testing. Now, any patient diagnosed with breast cancer in less than 45 years should be tested for BRCA, irrespective of the age. If patient is diagnosed with TNBC, lobular breast cancer, metastatic breast cancer, male breast cancer, or more than one relative with a male breast cancer, or of course, if they have ancestry of Ashkenazi, so they are supposed to get tested for the BRCA positivity. Other than that, patient with 46 to 50 years with unknown or limited family history of multiple breast cancer at any age, or more than or equal to one relative with breast, ovarian, or pancreatic or prostate cancer at any age, they are supposed to go for BRCA testing. More than 15 years, there are some criteria like more than equal to one relative with any breast cancer with a history of less than 50 years, male breast cancer, ovarian cancer, pancreatic or prostate cancer of any age, more than 3 are equal diagnosed with breast cancer in a patient or relatives, or more than 2 are equal relatives with either breast cancer or prostate cancer at any age. So the breast cancer testing, BRCA testing for breast cancer criteria has been much more relaxed what we used to see before. Of course, ESMO also has come out with some guidelines whom to test BRCA testing. Almost the ESMO NCCN guidelines are similar, except there is some difference in the age. So why we should know BRCA status? Because it will have a much impact on the treatment. Like I said, if a patient is diagnosed to have BRCA positive, maybe patient want to go for contralateral prophylactic mastectomy also. That could be a very big implication if a patient is turned to be BRCA. Other thing is that if BRCA status is there, there could be a reason we should start the patient on olaparib as an adjuvant treatment in some of the patients. So BRCA status do have an impact in the treatment outcome. So BRCA status should be explained. So in that way, it's very important that we know BRCA status, and it will help us to plan the treatment further. So this is the preoperative genetic test impact. So in this chart, as you can see, that if the BRCA status is unknown, the people going for the contralateral prophylactic mastectomy is quite lesser. If you know, say the BRCA test and counsel them, probably patient who have finished a family or who are more concerned about the contralateral breast cancer may undergo contralateral prophylactic mastectomy. So if you have a BRCA test, what is the implication of that? If you have a pathological mutation present, then you can use it in a patient's management, and also it can be a predictive testing for the relatives when you want to do BRCA testing. If there is unknown significance genetic variation is found, then you must keep the patient under follow-up, and also you must keep on checking the literature. If you find that if there is any change in the literature evidence of that gene, then you have to call the patient and discuss him regarding what is the recommendation at that stage. Genetic variant polymorphisms are usually of a benign neutral variant. usually it doesn't have any much impact on the treatment, and that patients can be kept under follow-up. No mutation, if it is detected, then you must going to look into the what is the limitation of the test we have done. If it has a limitations, like for example, if you have done only germline, if you have not done somatic, or if you have done somatic, if you have not done germline, you can do additional test if you want to. Family members should be tested if they have a very strong family history. So those are all the some of the implications if you find a no mutation, and if you strongly suspect there is a family history of breast cancer. So this is the one of the very important thing is that even if a patient is presenting with early breast cancer, there are about 25 to 30% who may come out with the recurrence. Various factors do impact in that. The very important thing is that the ER/PR/2 status, TNBC patients tend to have a more relapse compared to other patients. The other one is the grade. If a patient is presenting with higher grade, they are more likely to relapse compared to the patient with lower grade. Other one is the T and N status. If they have a T and N status in advanced stage, they are more likely to relapse. The other very important thing is that these patients tend to have a systemic relapse than compared to that of the local relapse. So what are the clinical features which are majorly determine the patient relapse? One is that the tumor staging. The more the staging, more likely to relapse. Presence of positive nodes, again, high upstages the patients and they are more likely to relapse. Failure to achieve pathological complete response after neoadjuvant chemotherapy, probably it tells us that patient is having aggressive tumor and they are more likely to relapse. High CPS and EG score. CPS EG score is something that it is a clinical and post-treatment pathological stage, and also estrogen receptor and nuclear grade. Based on the various factors, the scorings are being given in this score. I'm going to talk to you about this in much detail, and based on the molecular test. We know molecular tests are the very important factors in the breast cancer. Benefit risk calculators, there are various calculators which are available in the world today, so which also determine whether patient will have high risk of relapse or not. The positive nodes, as I was telling, increase in the positive nodes do have a high chance of relapse. As you can see, in a ER positive patient who have got more than nodes more than 4 have more relapse compared to patient who have got less than 3, and more patient who have got 1 to 3 nodes have more chance of recurrence compared to who have node positivity. Same thing with the TNBC patient. This is the DFS data showing in the Chinese patients. This is the real world data. So whether it's a TNBC, ER/PR positive or anything, nodal status is an independent risk factor for the relapse in early breast cancer. Failure to achieve pathological CR after neoadjuvant chemotherapy again increases the patient risk of recurrence, whether it's a TNBC or ER/PR positive. If you have a patient who doesn't have a pathological CR after neoadjuvant chemotherapy, they are more likely to relapse compared to patient who achieve pathological CR after neoadjuvant chemotherapy. So this is again the PCR status based in a TNBC patient, event-free survival and disease-free survival. Ultimately, patient who had a better pathological response after chemotherapy have a less chance of recurrence compared to that of the patient who didn't have. So CPS and EG staging system, again, I was telling you, this is the one of the staging system, which is a more little bit sophisticated because it takes more into the post-treatment changes, pre-treatment changes, and also some of the pathological and clinical stage. It seems to be a more better assessment tool to assess the chances of recurrence in early breast cancer. So it will take into factors like clinical stage, pathological stage post-treatment, receptor status, nuclear grade. So it's some of the all those things scores, and based on that the total score is being given. The higher the score, the more chance of relapse in CPS and EG score. So this is again the data which is showing the patient who had more of a CPS EG score are more likely to relapse compared to the patient who have got less score. So as you can see that the patient who had got score of 0 have less chance of relapse compared to the patient who have got 5 or 6. So same thing, this is the disease-free survival which is seen in trials. So the CPS EG score is more used in clinical trials rather than used in the practical or guidelines. So this is the score which is used in a clinical. So basically there was no any treatment based on this score, so hence it was not used more in the clinical. So it was used in a clinical trials rather than using it more practically in day-to-day practice. So molecular test, we know a molecular test. Molecular tests are basically done in us to predict or decide on adjuvant treatment, especially Oncotype DX, Mammoprint, Endopredict. These are some of these tests which we do. Based on the risk score, we decide whether to give adjuvant chemotherapy or not. In India, we also have a score of can assist. Based on that, we also decide whether to give adjuvant chemotherapy post-surgery or not. So there are various calculators available. I remember that when we were postgraduates, we used to use Adjuvant online. Now we have breast cancer treatment outcome calculator. So there are various calculators. Some people use whichever the calculator we are more comfortable with. They are the way which will tell that this could be a patient with high risk, where you can decide on the treatment based on the risk calculation or not. So Rcb index is one more the index. It's basically the index which looks into the residual disease following a neoadjuvant chemotherapy. It usually assesses the primary tumor size, percentage of the tumor cells which are present, and lymph node metastasis. So if the patient is having the more RCB score is basically graded into grade 1, 2, 3. Patient with RCB grade 3 are more likely to relapse irrespective of the triple negative or two or anything. So patient with high score are more likely to relapse compared to that of the patient with lesser score. So as I was telling, the RCB1 is minimal, RCB2 is moderate, RCB3 is called as extensive. The score is which is given is more than 3.28. So it is basically calculated based on the primary tumor bed area, overall cancer cellularity, percentage of cancer that is in situ disease, number of lymph node positivity, diameter of the largest metastasis, residual cancer disease is basically classified on all these things. So based on that is graded as grade 1, 2, 3. So people with a RCB burden of 3 are more likely to relapse with the disease compared to that of the RCB1. So what does it impact if there is a residual disease post-treatment? The post-treatment, the residual impact is that if there is a residual disease in HER2 positive disease, we can plan giving TDM1. So we can also modify based on that in TNBC regarding the immunotherapy or PARP inhibitor. So residual disease post-treatment will have a treatment implication. So patients with non-residual disease are going to do better than compared to patients who have got residual disease. So optimal patient treatment depends on various factors. Very importantly, the stage in which patient presents, and also the what is the number of lymph nodes involved, grade, and also ERP or HER2 status. And we have got many options available to us, starting from genetic test, the calculators, to the pathological factors. Taking all these things into consideration, we can consider the patient treatment in the future, so that it is going to be a major impact on the patient treatment, so that his survival is improved. So in summary, despite being the most treatable cancer today, despite being so much advanced in the breast cancer, we see 20 to 30% of the early breast cancer recurrence in first 10 years. So very important to cure in an early stage, because metastatic disease, once it's come, it will more into a palliative stage. We know we can't cure them at that this thing. Patient with BRCA mutation require a proper plan, because BRCA impacts the treatment, especially in the surgery aspect. Because if some patient want to undergo, prophylactic mastectomy, we can offer them. And also BRCA do have a targeted therapy which we can use for the patient's benefit. So we have various risk models depending on the institute and individuals. They do follow various risk models, but we also have many models based on the genetic risk factors, genetic score, and also we also have various risk factors based on the pathological features. So taking all these things into consideration, treatment plan should be done accordingly and patient should be treated. Thank you.
I thank Dr. Suresh Babu sir for that wonderful delivery of that scientific. Next I welcome Dr. Mangesh Kamath for his talk.
Thank you, Dr. Srinivas. Let me share my screen. So with that wonderful introduction on basically risk stratification and also scoring of breast cancers, it would be actually making my job easier while I talk about management of early breast cancers. I hope my screen is visible to you and I am well audible to you all.
Yes, sir. You need
Thank
to,
you.
yeah.
Yeah, so I'm on full screen mode. Is that also clear?
Yes, sir. Yes.
Okay. So thank you very much again, AstraZeneca, for this opportunity. I would also like to thank Dr. Srinivas for bestowing this opportunity to talk about a very interesting topic. I say interesting because there's a lot of studies going on in the medical management of early breast cancer. And if there is a lot of study going on in the HER2 positive space, there are also a lot of studies going on in the HER2 negative space. We all are looking at a lot of data which is coming out with respect to targeted therapy, immunotherapy, monoclonal antibodies, antibody drug conjugates when it comes to early breast cancer. But while we are also keeping pace with those expensive, probably, and also a little cumbersome protocols, we are also trying to see how we can use the already existing pieces of our armory and try and achieve better results in early breast cancer. Now, when I say early piece, the pieces of our armory, they are mostly the chemotherapeutic agents. And we are still learning about what could be optimal. There is a lot of controversy regarding the utility of various chemotherapy drugs, such as platinums and capecitabine and so on and so forth. So I believe that we have to try and find out which is the most optimal regimen in the management of early breast cancer. So I will try to dwell on that and then go to the rest of my presentation. I just need to be able to run my slides. So give me a second. Yeah. So we want to understand one thing, that is it essential for us to understand, for us to know that BRCA mutation is present in a patient that we're treating with early breast cancer? A lot of us would probably say yes. Some of us would say no, because we are actually looking at what would be the clinical utility of knowing that this patient has BRCA mutation or not. So that makes it very, very useful for us. I'm sorry, I'm not able to get this top panel out. I wonder how it's possible. Facing some trouble with that. Just I'm not able to get the top panel out. I don't know if you can all see that, right? Yeah. So when we are usually looking at, can you all also see the top panel, or only it's me that I'm seeing on my screen?
No, sir, we can
We are
see.
seeing the top panel, Mangesh.
No, when I say top panel, in my screen, I have the mute and stop video are still listing. So basically my slides, I can't read the top panel. I mean, the title panel of the slide. I don't know why.
We are actually able to see your top panel.
Just hold a second. I don't know, some technical stuff. Because without
just move
that,
the slide and
the first time it's happening with me with all this.
So, but we can see like the top line is as.
No, I am unable to see. I now get that you. Okay, yeah, I got it right now. Okay. But I don't know now. I can't see the bottom panel now. Okay, let me see if I can do that. Okay. So a detection of germline BRCA mutation significantly impacts a patient's care plan in the metastatic setting. We totally understand that. We know that because we have been inundated with a lot of data about the utility of PARP inhibitors and so on and so forth. But we should understand in general, whether it's early, locally advanced or metastatic, the germline BRCA mutations patients are often younger and they present with a lot of aggressive disease. So your regular therapy, which you otherwise give for whatever, it could be a hormone receptor positive or triple negative, you usually tend to see a lot of a very aggressive disease. It can alter your surgical decisions and therapeutic options. Dr. Suresh Babu has alluded to it, but many patients do not meet the common testing criteria. That's very important for us to understand. We do have the criteria given by NCCN, but sometimes there are a few patients who may not be actually conforming to all these criteria, but may actually still be harboring the germline BRCA mutation. Now, how do we avoid missing such opportunities? Because these patients could benefit from targeted therapy, whether it is in a metastatic setting, but also in the early setting. So there is a lot of data coming out that if you were to not apply many of the selection criteria for testing for BRCA mutation, you would find that the prevalence is approximately 5% overall. You could find that, and it is based on studies done in various countries. They wanted to understand whether you really are missing out on some patients who are not conforming to the NCCN criteria.
So there is a conflict between way of life and radicalization. और जो आपने बात बोली गर्दन काटने वाली बात.
Sorry, is there somebody else speaking?
Support team, can you mute? Support team.
Done, ma'am.
Hello.
Yes, sir, you can proceed. You can go ahead.
Yeah, so sorry for that. Yeah, so basically the BRCA mutations in Indian patients has been studied as well. And this question has been asked whether we also have some sort of a difference in the criteria or not. And then it's very important for us to understand that, yes, there are a lot of patients who may not be conforming to the criteria, but they do have BRCA mutations in them. And it has been found across studies that it is possible to get BRCA mutations in around 10 to 15% of the patients. So there is data available to suggest that 50 to 80% of individuals at risk of having an hereditary breast cancer are never tested as they do not meet the current criteria. So that's a very important point for us to understand. And I have a feeling that while we also have a lot of these criteria very well by hearted, but we don't apply it a lot of times because we don't know what exactly are we going to do with that data. And that is a very important question that we keep answering ourselves because of the cost constraints that patients have. So when it comes to that, we want to understand just that, okay, at least let us test the younger patients who are less than 50 or less than 45 years old, and maybe the older patients who may be having multiple other criteria like a family member having breast cancer. This slide has been touched upon by Dr. Suresh Babu. I will not get into it, but overall, there are some guidelines, but at some particular time, we should use our clinical instincts and also test these patients for whether they have certain mutations or not. Now, I may have talked about BRCA mutation, but we also need to talk about multiple other mutations. And it has been a standard across medical oncologists for us to test for any mutations that may be hidden to our eyes when we get something which is not conforming to our regular practice. If you get a patient who is progressing on endocrine therapy, then we want to know if there are some mutations in the receptors or any other downstream pathway receptor, downstream pathway mutations. So that is going to be our quest and management of patients who don't conform to our regular practice. So this is a very good study that I'm going to touch upon, the Olympia study. I know this study was published way back in 2007, but we do have an update this year, and that is what I'm going to touch upon while I'm running through this study. It is a phase 3 study of olaparib versus placebo as adjuvant treatment for high risk germline BRCA mutated HER2 negative breast cancer. And they selected patients with stage 2 and stage 3 breast cancer who are HER2 negative. They could have been hormone receptor positive or TNBC, completing the neoadjuvant or adjuvant. So they allowed both the neoadjuvant group and the adjuvant group to come into the study. And as the scoring was mentioned, the CPS plus EG score was studied, and the score would have been more than 3 in the neoadjuvant group. In the adjuvant group, they would have had at least node positivity requirement in TNBC and HR positivity in more than four positive lymph nodes. After they completed the neoadjuvant therapy, or if after they completed the surgery and then adjuvant therapy, they would be randomized to receive a maintenance of olaparib 300 mg BID versus a placebo olaparib twice daily. Now, this maintenance was studied for 1 year, and the primary endpoints that were studied were invasive disease-free survival, the distant disease-free survival, overall survival, the BRCA1/2 associated cancers, health-related quality of life, and safety. So the stratification factors were HR positivity versus TNBC, neoadjuvant versus adjuvant, and prior platinum-based chemotherapy or not. Around this time, there was a lot of talk about platinum agents being required in TNBC. So this was also something that they looked at while studying, while looking through details of the study. So they studied the CPS plus EG score. I will not go much into it. It has been well described earlier. So basically, excuse me. Yeah. So basically, it was something.
Slides are not moving.
Yeah. Now.
No, sir. It is showing BRCA mutations in Indian patients.
No, my slides are, in my screen, they're moving quite well.
No, sir, can't see your slides. Can you reshare again?
Yeah, 1 second. Can you see now?
Sir, just make it full screen.
Now?
So it is now on indications for 1 year of adjuvant olaparib. Is it right?
Yes.
Okay, sir. Thank you.
So, yeah. So then they basically looked at how olaparib made a difference in the adjuvant setting or as a maintenance therapy, and they found that the bottom curve is the one that is with the placebo, and the curve on top is the one with olaparib. So at around 3 years, you would find that the invasive disease-free survival was 85.9% and 77.1% for olaparib and placebo respectively. The hazard ratio was 0.58. So in essence, olaparib reduced the risk of invasive disease recurrence or death by 42% versus placebo. That is a very big difference when we look at number of patients that were taken in the study and the timeline that was also checked in the study. So it makes it, it makes us take note of it. Then, if you look at the secondary endpoint of distant disease-free survival, again, the hazard ratio was very, very notable. And if we want to know whether all this translates into a good overall survival benefit or not, so let me come to the data to that. So then they went into what is called as data cutoff 2. That means after the end of the initial analysis, they went for an additional 1 year of follow-up. And they found that the hazard ratio didn't change significantly. It was 0.63. That means 37% of the patients benefited compared to placebo. If I reminded you earlier, it was 42%. So the difference was well maintained very well. And even the distance disease-free survival benefit was maintained with an additional 1 year of follow-up. So it is clear that with an additional 1 year follow-up, there was a benefit both with respect to invasive disease-free as well as distant disease-free survival with adjuvant olaparib. Then the secondary interim analysis, which takes us note. So we know early breast cancers, they have a long history, even if they ever to recur. So an overall survival probably gives us a lot of pat on the back while you are using and recommending this drug, which is currently expensive. So the overall survival at a 4-year update, and this was published in March 2022 at an ESMO plenary, and this definitely showed that the 3-year overall survival rate was 3.8 difference, and the 4-year overall survival rate was 3.4% difference. And if you see, they've kept a very strict significance boundary of 0.015, and the studies follow-up showed that the p-value had crossed the significant boundary significantly. I don't know if there is a word that you can use, significant to significance, but this was clearly outside the boundary that was stratified. And if you see the stratified hazard ratio, it was 0.68 and the confidence intervals are well within 1. So with this data over a 4-year update, can definitely tell us that in those patients who have germline BRCA mutation, and if they if they have completed successful neoadjuvant adjuvant therapy and surgery, and they could be definitely recommended to undergo olaparib. Now, the one major challenge in interpreting this study is there were hormone receptor positive.
Hello, sir, we cannot hear you. Hello, Dr. Mangesh. I think there is some connectivity. So, Srinivas, sir, can we proceed with another talk?
We'll wait for another 30 seconds.
Okay, sir. Sure. Sure, sir.
Could we get Mangesh? Hello.
Hello. Yes, sir.
Could we reconnect to Mangesh?
Yeah, I just reconnected back. There was some issue in the application just logged me out. Can I continue?
Please, we'll.
Yes,
Yeah,
yes. I'll probably try and rush through some because I think we lost some 2-3 minutes there. I hope my slides are visible. I'm just going to rush through it. Yeah.
I have slides are visible.
Yes. Thank you. Yeah. So where I was probably disconnecting was that we are looking at olaparib being a very good molecule to be used in the adjuvant setting. But at the same time, we want to understand whether olaparib is definitely better than endocrine therapy, especially because we know that endocrine therapy is the standard of care in hormone receptor positive breast cancer. And at the same time, we have a lot of data that's coming up in the TNBC setting as well about maintaining with capecitabine. And so whether, olaparib is going to be better than capecitabine in helping us prevent the recurrences as well as helping improve survival, that is something we are not aware of. But at the same time, let us run with the data that is there, because it is something that takes notice of the fact that in germline BRCA mutation, we can definitely recommend olaparib as a maintenance therapy for 1 year. This is a good study called as brightness study, wherein they wanted to study wherein whether the addition of carboplatin to paclitaxel in TNBC, would that be better than just plain paclitaxel, number one? And the number two purpose of the study was, can we add veliparib, another PARP inhibitor, to paclitaxel and carboplatin and improve on the combination of paclitaxel carboplatin. So if you see the blue box here, that is paclitaxel only, along with the placebo for carboplatin and placebo for veliparib. And the one that you see in pink or peach, that would be paclitaxel plus carboplatin plus the placebo for veliparib. And the one in green, the olive green, would be paclitaxel plus carboplatin plus veliparib. Now, with one picture, I can probably tell you that compared to paclitaxel, they found that adding the carboplatin to paclitaxel, followed by continuation with the doxorubicin and cyclophosphamide, significantly improved the pathological CR rates and translated into an improved EFS after a median follow-up of 4.5 years. Veliparib did not impact the PCR, EF or OS compared to paclitaxel and carboplatin, nor with because of the simple fact that just paclitaxel carboplatin would be giving us the benefit over paclitaxel. So the veliparib addition did not actually add to the paclitaxel carboplatin. In fact, if you see here, the pathological complete response was probably lower with the veliparib addition to paclitaxel carboplatin. So if you see the curves on the right side, they are very similar. So the blue one is with the paclitaxel only, and the ones with the maroon would be paclitaxel, carboplatin, and veliparib. Not much differing between paclitaxel and carboplatin. So that is the purpose of this study, and it is now clear that carboplatin can be utilized in the neoadjuvant setting, and we can definitely get a better response than just paclitaxel. However, whether that translates into a significant overall survival benefit is over a period of time has to be seen, because it is very clear that addition of carboplatin to paclitaxel helped the CR rates and the EFS rates. Whether it is truly helping in the overall survival benefit is something we'll have to see over a period of time. So what are the latest developments in HER2 negative EBC management? So the FINEX study, again, it is a study which was published a long time ago. Basically, this study, they are providing the 15-year update of this, whether the addition of capecitabine to taxane and anthracycline chemotherapy improved the OS during the median follow-up or not. And this would be in the axillary node positive or the high-risk node negative EBC. So the study design was very simple. There are many institutes that are using 3 FEC and 3 docetaxel. So what they wanted to do here is replace the 5-fluorouracil with capecitabine whenever instead of the FEC, and add the capecitabine to the docetaxel. So basically, you are adding capecitabine with the anthracycline and capecitabine with the docetaxel as well. And this was a study which included almost all the subgroups of that time which are known, such as ERPR positive, ERPR negative, then the HER2 positive, HER2 negative, and all those varieties were taken, all the subtypes were taken, and they wanted to study what would be the benefit. Now, if you see this overall, that means if you are unstratified patients across all the subtypes of breast cancer, they found that the hazard ratio was 0.81 with a favorable confidence interval. And then they also found that in those patients who are HER2 negative, again, without touching the confidence interval, there was a significant benefit in the hazard ratio for the HER2 negative groups with the addition of capecitabine. So in the triple negative, this was even more pronounced. They found that the hazard ratio was 0.59 with good confidence intervals. And over a period of time, they have found that the overall survival benefit of addition of capecitabine, there was a 4% or a 4 percentage point difference between addition of capecitabine versus non-addition of capecitabine with docetaxel. So this
Did Dr. Mangesh again lost his connection?
Yes, sir, it seems to be. Yeah. Srinivas, sir, can we proceed further?
I think so. We'll move on to next session. I welcome Dr. Vishwanath. Dr. Vishwanath, are you there?
Yeah, I am there, Dr. Srinivas.
So I welcome Dr. Vishwanath for the next presentation. Dr. Shekhar Patil sir is there.
I'm back. Do you want me to stop? Sorry.
Oh, you got it back?
Yeah, back. Yeah.
Just
there's no problem with the internet. It's just throwing me out. The Zoom this thing is just throwing me out. That's all.
I think what you can just do it. Mangesh, just conclude the talk, no?
Sure. Yeah, I can do that. No problem. So I'll just run through that part wherein I'll just probably summarize whatever little I can. So basically, I was coming towards the end of this, the talk with basically some slides about immunotherapy, role of immunotherapy. So I'll skip all the major ones and I will just come down to the immunotherapy conclusion. So what we can talk about in immunotherapy is that we do understand the role of pembrolizumab and atezolizumab in a metastatic setting, but whether we are ready to introduce pembrolizumab and atezolizumab for that small value that we get in the triple negative setting, especially when we can cause some very major irreversible severe side effects, are something that is completely to debate. Are we looking at a significant survival is something we are not very sure of. The second thing I wanted to touch upon is the role of adjuvant CDK4/6 inhibitors. It has been found in the Monarchy study that abemaciclib plus ET demonstrated a statistically significant improvement of IDFS versus ET alone. And there are some benefits in the recurrence, distant recurrence-free survival point as well. And additional follow-up over a period of time has shown that there is benefit by around 30% in the risk of developing an IDFS event with respect to not adding of abemaciclib. And the Penelope study, again, the one with the palbociclib, that basically tells us that there is role for addition, but again, it has not been found to improve upon the adjuvant endocrine therapy. So abemaciclib has shown that, but palbociclib has not shown that. Maybe it's the it's the efficacy of the molecule, and there is definitely no difference of adding PARP inhibitors to those patients or subsets of patients who have germline BRCA1 or 2 mutation. Overall, like I said, the questions that are still to be answered are: should pembrolizumab be added to olaparib, especially for those patients who have germline BRCA1 and 2 mutations, and especially those who have residual disease after neoadjuvant therapy? The second question that could be asked is: do you want, should we prefer olaparib or capecitabine on those patients with TNBC and residual disease, especially when they are harboring germline BRCA2 and BRCA1 mutations? And the next question to be asked is: are we going to use adjuvant olaparib or a CDK4/6 inhibitors in those patients who are hormone receptor positive? I'm leaving you with a lot of questions, but at the end of the day, just to conclude, we know that the molecular biologies are impacting our therapies in the early breast cancer setting. And not only early breast cancer setting, we are now trying to understand whether we can develop maintenance strategies. Earlier, maintenance strategies were there for hormone receptor positive. Can we use maintenance strategies for hormone receptor negative, as well as those subtypes depending on the BRCA mutation? And even slowly we might be going into HRR and HRD segments as well. That is something that further trials are going to help us. We are currently probably given a lot of data on immune checkpoint inhibitors. I am not really convinced that we should be using it so soon, but even if we use it, there must be a very, very clear demarcation when we can use them. And so we need to understand the role of these agents and try and see where we can achieve the best outcomes for patients. Early breast cancer patients are going to be very important with respect to that, because the more we can prevent the recurrences and also help get higher cure rates, the more we will value each of these agents depending on what results that we see. Thank you very much again for your patient hearing, and I really appreciate again Dr. Srinivas for having conducted this conference, and AstraZeneca as well for giving me this opportunity. Thank you.
Thank you, Mangesh, for that excellent presentation. As you rightly said, immune combination of PARP inhibitors and immune checkpoint inhibitors, actually the data was actually presented in this ASCO 2022. We have the presentation. Dr. Bharat Rangarajan is going to talk about that in the later presentations. Now I welcome Dr. Shekhar Patil sir to chair this session. Good evening, sir.
Good, thank you.
I also welcome Dr. Vishwanath, who is consultant in Apollo Hospital, to deliver his lecture. Dr. Vishwanath.
Yeah, I hope my slides are visible, Dr. Srinivas.
Yes.
Yeah. Yeah. Good evening, everyone. At the outset, I would like to thank Dr. Srinivas for this opportunity, and also Dr. Shekhar Patil for chairing this session. So the two trial sets which Dr. Srinivas has asked me to present. So one of them is the neoadjuvant phase 2 study of pembrolizumab and carboplatin plus docetaxel in triple negative breast cancer. It's also called the NeoPAC trial. It was presented by Sharma et al. So this is the background. We know that the addition of neoadjuvant immune checkpoint blockade to the anthracycline-based chemotherapy.
Vishwa, your slides are not moving.
Oh, is it? Now?
Yeah.
Okay. So we do know that the addition of neoadjuvant immune checkpoint blockade to anthracycline-based chemotherapy leads to the improvement in the pathological complete response rates. And some studies have also demonstrated improvement in the long-term outcomes in the early stage TNBC. So we also know from the various other study data sets and results that carboplatin and taxane neoadjuvant regimens provide encouraging pathological complete response rates in TNBC. And with the FDA approval of the pembrolizumab based on the Keynote 522 study, the 5-drug regimen of Pacli plus carbo plus pembrolizumab followed by anthracycline-based chemotherapy and pembrolizumab, and adjuvant pembrolizumab has become the de facto standard of care for most patients with stage 2 to stage 3 TNBC because of the excellent PCR rates. But again, strategies to de-intensify, we are slowly moving out of the anthracycline regimens, including the HER2 positive breast cancer. So in order to de-intensify neoadjuvant systemic chemotherapy for TNBC patients without compromising outcomes, this particular study was designed and to look at if anthracyclines can be omitted. So this is the study design. Basically, it was a phase 2 study in triple negative breast cancer. So patients from stage 1 to stage 3 TNBC, tumor size of more than 1 centimeter or node positive, ER/PR should be at least should be less than 10%, and total number of patients were 120, and the treatment was for 18 weeks. So carboplatin, the usual AUC 6 with every 21 days for 6 cycles, along with the docetaxel standard dose of 75 milligram per meter square. And along with that, pembrolizumab, the standard dose of 200 milligrams every 21 days for 6 cycles. And after 6 cycles, the patient underwent surgery. The primary endpoint was pathological response, and the secondary endpoint was the RCB, which Dr. Suresh Babu alluded to, the residual cancer burden, and the EFS and OS and safety, and also correlative studies. And then the patients were followed up. No adjuvant pembrolizumab was allowed, was according to the protocol, and the adjuvant therapy was decided by the provider. Now, these were the various methodologies which were used. So pathological complete response, the definition was no invasive tumor in breast or axilla. And then there are various predictive other markers which were used, like DNA damage immune response, DDIR, which was a 44 gene next generation sequence assay for predicting the immuno-oncology response. Basically, the report was given as positive or negative. If the report was positive, it was again considered that the immune it was highly predictive of response by immuno-oncology drugs. And then there was something called Determa-IO, which is again a 27 gene NGS assay. Again, positivity predicts response to IO. And then the stromal tumor infiltrating lymphocytes, again, which again predicts the response to IO. And then the PDL1 by the 22C3 method, which looks at the combined proportional score of anything more than 10 or more was considered significant. Now the EFS, we know the usual definition, and the PCR and RCP 0 or 1 was estimated, and all the statistical analysis was done. So this is the patient characteristics. 115 eligible patients enrolled, and out of that 109 patients were evaluated for pathological complete response. And what is important here, you can note here that if you see here, around 81% of the patients had at least T2 or more, and around 39% of the patients had node positivity, and 75% of the patients in the stage 2 and stage 3 in 13% of the patients, and around 85% of the patients had complete ER negativity, ERPR, and a few of them did have 16% of them had at least 10% of 1 to 10% of ERPR. And what is also important to note is that around close to 50% of the patients had a stromal tumor infiltrating lymphocytes of at least 30% or more. And the PDL1 of CPS score of at least 10 or more was again close to 50% of the patients. So what is interesting to note here is that of all the patients, you can see here the darker purple ones are basically the pathological complete response, and the lighter ones are the RCB 0 or 1. And you can see here that in all patients, the PCR rates were around 58% and 69% in patients with RCB 0 or 1. And you can see excellent PCR rates even in node positive disease, and ERPR negative. You can see 72% of them had RCB 0 or 1, and close to 60% of them had had a PCR. And what is also interesting to note that PDL1 positive patients had excellent PCR rates and RCB 0 or 1 as compared to PDL1 negative. And also important to note is that no patients had disease progression during neoadjuvant therapy, which is pleasantly surprising. Pathological response by immune markers, again, you can see that there was a good concordance between all the three predictive markers, and you can see 76%, 71%, and 81%. All three of them, the markers, the NGS assay as well as the stromal tumor infiltrating lymphocytes assay, showed that there was a good concordance in predicting the immune oncology response. And you can see here the odds ratio, and again predictive that those who had a positive result by the DDIR or the Determa IO, or if the tumor infiltrating lymphocytes was 30% or more, you can see that the odds ratio was high and was predictive of response. And here you can see that a median follow-up of around 2 years. You can see that the 2-year EFS in patients who had a PCR rate was 98%. That is phenomenal. And you can see here that it was 89% in all patients, and those who had a residual disease is what side was 78%. And the adverse effects grade 3 or higher treatment-related adverse effects were observed in around 26.9% of the patients. And the most common grade 3 or higher treatment-related adverse effect was diarrhea. And going on to the immune-mediated adverse effects, around 27% of them had immune-mediated adverse effects, but only 4.3% of the patients had grade 3 or higher immune-mediated adverse effects, and the most common was actually colitis. So to conclude, the NEOPAT study shows encouraging PCR rates of 58% with neoadjuvant, I would say, anthracycline-free regimen plus the immuno-oncology drug regimen. And these are very much comparable to the PCR rates when compared to anthracycline-based regimens with immunotherapy. And that is, again, quite nice to know that. And we also, they reported a EFS of 89% in the study, with only 5% of the patients having received adjuvant pembrolizumab. So that is again, so it goes to say, especially in a resource limited setting like our country, where adjuvant pembro will become very much expensive, it is actually good to see this. And excellent outcomes, EFS of 98% noted in the setting of PCR. And so basically raises question of whether you want to actually give adjuvant immunotherapy in patients who have had PCR. And also immune enrichment by all these different assays showed a good concordance, and there was a very good pathological complete response. So it goes to this study basically has definitely a phase 3 study is required to see if we can omit anthracyclines in the neoadjuvant setting. The second study is again a phase 2 study of response guided neoadjuvant sacituzumab govitecan in patients with localized triple negative breast cancer after its major success in patients with relapsed metastatic multiply treated triple negative breast cancer in the metastatic setting. So this is the NeoStar study. It's from the Mass General Hospital. We can also see popular names like Dr. Sara Tulini and others. So you can see here that the baseline patients with T1C to T4, any nodal disease, triple negative breast cancer, 50 patients, not too much of number, baseline biopsy, imaging, and then sacituzumab govitecan once in 3 weeks, 4 cycles, stratified based on age and lymph node positivity. And after 12 weeks, the patients were imaged, and those who had a residual disease underwent a biopsy, and they had to undergo a couple of more cycles of neoadjuvant therapy and then went for surgery. Otherwise, patients who had a very good response went on to undergo surgery after 4 cycles itself. either BCS or mastectomy, and then adjuvant chemotherapy as per the investigator discretion. So the primary objective was PCR rate or in the breast and lymph nodes and with sacituzumab govitecan and monotherapy. And the secondary endpoints included assessment of radiological response rate by the RECIST 1.1, safety, tolerability, event-free survival, and also quality of life by the URTC questionnaire. And explorative objectives included assessment of potential predictive biomarkers, including the TROP2 expression, PDL1, and the similar thing like the DNA damage response markers like the previous one, and the immunological markers, as well as changes in the cell-free DNA with the administration of this sacituzumab. So patients with localized TNBC were included or any size with node positivity. Otherwise, the tumor size had to be at least 1 centimeter or more. No prior treatment was allowed. And the dosage was basically 10 milligrams per kg body weight administered on day 1 and day 8 of a 3-weekly cycle. And after, like I told, after 4 cycles, if there was residual disease, patient had to undergo 2 more cycles. If there was good, complete response, then the patient could undergo surgery after 4 cycles itself. So 50 patients, median age of 48.5 years. And you can see that there was a distribution across the stages. And 9 patients actually had a germline BRCA mutation positivity as well. And PCR rates with the SG alone was 30%. And radiological response rate with SG alone was 42%, which is again quite good. And you can see here, this is the schema. 50 patients, out of that 29 patients directly went to surgery after SG, but additional neoadjuvant chemo, which could be anthracycline based regimen, or it could be carboplatin or taxane, or it could be docetaxel or cyclophosphamide in this other patients, 2 more cycles. And those patients were around 21. And you can see here impressive PCR rates and RCB rates. And what you can see here is that overall the PCR rates were around 30%. And you can see here in BRCA mutated positive patients, the PCR rates were quite high. So 6% of patients required dose reduction. No patients discontinued SG therapy due to disease progression or adverse effects, which is again good. And 1 discontinued due to minimal response as per the investigator discretion. So the authors concluded that this is in the first neoadjuvant trial with this particular drug, the antibody drug conjugate in TNBC. This drug definitely demonstrated a proof of principal clinical activity as monotherapy, and definitely further research and further randomized phase 3 trials and optimal duration of SG, as well as the neoadjuvant combinatorial strategies, including with immunotherapy, are needed. Yeah. Thank you so much for a patient listening.
Thank you. Thank you, Dr. Vishwanath. Are you able to hear me, sir?
Yes, sir. Yes, sir.
Yes, sir.
Yeah. Thank you. And very nice presentation. And both articles were very good. Particularly the first one, which looks like we have to look into it seriously, because we had all these days the data with the anthracyclines, taxanes, carboplatin with the pembrolizumab in triple negative breast cancer. Now, without even adding anthracycline also, we are able to get such a high pathological response rates is a good thing, because now we can reduce the toxicity. And still, I can't say that as a practice changing or tomorrow we should practice, basically because the amount of toxicity when we combine with the immunotherapy drugs are also quite significant. Sometimes they can be life-threatening also. And second, we don't have a survival data only based on the improvement in the pathological responses. We cannot change our practice, but definitely this is one of the good studies. We should look into it. We should have more studies, particularly the phase 3 studies in that direction should be a good thing for us to take a decision. Second is about the second study about the TROP2 inhibitor. We had all these days with the metastatic disease showing a significant improvement in the PFS and some amount of benefit in terms of survival. But now with the neoadjuvant, in the neoadjuvant setting, in particularly the triple negative breast cancer, we can see a significant high pathological CRs or good responses are seen. So I think this may be one of the good drug and very least toxicities, as Dr. Vishwanath pointed out in that study. maybe one of the good drugs in the coming days, maybe in the triple negative patients, both in the metastatic or in the neoadjuvant setting. So I think both the studies were quite interesting and nicely brought out all the points by Dr. Vishwanath, and it was a good studies to conclude. Thank you, Dr. Srinivas, for inviting and for such a wonderful scientific meet you have conducted it. And I think we are learning a lot in the coming days also. Thank you.
Thank you very much, sir. That was a very valuable input you have given to us, sir. And I also thank Dr. Vishwanath for his wonderful presentation. And I thank Dr. Shekhar Patil for his wonderful inputs. Now we'll move on to the next session. Dr. Rajesh, I welcome Dr. Rajesh, who is a radiation consultant, radiation oncologist professor in CMC Vellore, for his talk on adapting the radiation approach to the patients in breast cancer. And this session will be chaired by Dr. Vishweshwaraya, sir. Good evening, sir.
Good evening.
So now I welcome Dr. Rajesh for his presentation.
Good evening, Dr. Srinivas, and good evening to all the delegates and the faculty people. Thank Dr. Srinivas for the opportunity for giving me to talk in this forum. I also like to thank Dr. Somashekar, who has agreed to slightly reschedule because of my other commitments. Today, I'm going to talk about the adapting radiation therapy to the surgical management. I'm going to present the slides which are presented by Dr. Wendy Woodward in the conference. I think the slides, are they moving? Yeah.
Yes,
Okay.
yes, sir.
So the learning objectives of this talk would be like when and how to target the axilla with radiation after an upfront positive sentinel lymph node biopsy. That is the first question which you're going to learn. And the second question is how to target the axilla after neoadjuvant chemotherapy. Both these scenarios have been discussed by Dr. Wendy Woodward only in the early breast scenario, that is T1, T2, N0, N1 scenario. It doesn't apply to any locally advanced scenarios. So this is the first scenario where you try to see in clinically N0 patients, when you do sentinel lymph node biopsy, what is the management protocol? So if the sentinel node comes negative, there is no further axillary treatment necessary. But if they are positive, according to this Astra Trial, that is which included patients with T1, T2 with 1 to 2 nodes positive, they were treated with radiotherapy with breast conservation therapy, that is whole breast plus surgery followed by RT. So if they are not included into this trial protocol, that is ACOSAT was more than 3 or more positive nodes, they need to follow some other algorithms. So coming to the first scenario, in the upfront surgery part, when there is 2 or less nodes which are positive. So in this scenario, what we are going to see is this trial inclusion criteria included T1, T2 clinically N0 nodes, but sentinel nodes were 1 to 2 nodes are positive. So when they were having 1 to 2 nodes which is positive, they were randomized into 2 arms. One arm was like complete axillary dissection, and they were supposed to remove 10 or more nodes, and the other arm was observation. That is, they gave RT to the breast alone in the breast conservation surgery patients. They did not treat the axilla with radiation. So what they found out is even though the axillary lymph node dissection had 27% of them had additional nodes, when they saw that the 5 years and that is the 8-year and the 10-year survival rate between the 2 arms, where the axilla was treated and the axilla was not treated, did not have any significance. So this is the first paper published by Gugliano in JAMA 2011, where they showed 5-year survival, which was similar to both the arms. And in the updated paper, it was even up to 10 years, this significance was still present. It did not show any difference even for patients who are ERPR positive separately or ERPR negative. So the receptor status did not make any difference in this group of patients. So why dissection did not matter in this study? These are the 4 questions they wanted to address. First question was whether residual disease in the axilla is it clinically relevant. Second one is whether the patients with residual disease were very few and the study was not powered enough to detect any benefit, or whether the residual disease in the axilla is adequately treated by the systemic treatment or by the radiation. To address this question, they try to look up into all the other matters. So usually when you treat breast with tangents, you can see that there is a medial tangent which is coming from here and a lateral tangent coming from here. When you put the tangents, the axilla will not get included into the field. Suppose you want to include the axilla in the field, then you might need to tilt your lateral tangent slightly bit so that you can try to include the axilla in the field. But the disadvantage with this part is you get slightly additional dose to the loss. So when they studied the patients who were treated with this thing, they found that the usage of this high tangent field was very high in this protocol. Usually when you keep your lateral tangents, you try to keep the superior border at least 2 centimeters below the humeral head. So this is what you call it as standard tangential fields. And in this study protocol, what they found is majority of the patients had a high tangential field where the superior border of the tangential field was very close to the humerus. By keeping this superior border very close to the humerus, what they have found is by using high tangent, the level 1 and level 2 nodes can get up to 70 to 86% can be getting treated with only the tangential fields alone. And even the nodes, the 95% dose was near about 50 to 80%. So this was the study which they did, and they found this high tangents were being basically covered. And some patients, they were also treated with the 3-field technique where the supraclavicular nodes were also included into the treatment fields. So the level 1 and what they concluded finally was the level 1 and level 2 axilla was likely treated with radiation. Most of these patients, even though they were not separately treated for radiation to the axilla. And so when we want to treat in such a scenario, we can tailor our RT portals and we can avoid lymph node dissection. So coming to one more similar trial, AMAROS, what they tried to do in this AMAROS trial was they tried to replace lymph node dissection with axillary RT, and they found that the 5-year recurrence rates was almost 0.4 with the lymph node dissection arm and 1.19% with the RT arm. And they found that it is not statistically significant. So whether you do lymph node dissection or axillary RT, it doesn't make any difference in this scenario where the lymph nodes are 1 to 2 positive. So coming to the node positive patients, what they try to do is we need to understand how much of the axilla is not included in the field and try to add those parts with the part when we try to do it. And we also need to consider some risk factors in eligibility for MA20 trial to determine whether the patient would need comprehensive nodal irradiation. Comprehensive nodal irradiation meaning treatment of axilla, supraclav, IMC, all nodes positive. So this is a picture where you can see that there are 3 different guidelines which are used to contour the axilla: the RADCOM, ASTRO, and the RTOG. All these guidelines are varies in their contouring guidelines, and you can see it's all 3 we have overlapped and put into a picture where you can see that the differences are very different. Coming to the next part, on the upfront surgery scenario where the nodes are 3 or more are positive, sentinel nodes. So when the nodes are more positive, then we might need to go into additional algorithms to see what would be the benefit, and we should not definitely try to include them in the Z011 protocol. So there are 2 studies which shows benefit in this group, that is the MA20 and the URTC 22922 study. So what they try to say is when the patient's age is less than 40 or age is more than 40 with 1 to 2 lymph nodes with some additional risk factors like high Ka67 index, grade 3 tumor, these are the high local recurrence factors like LVSA, and RS score, that is the risk score by the Oncotype DX when it's more than 18, ER negative tumors, medial quadrant tumors, and premenopausal women. These are the patients whom we should consider regional nodal irradiation in addition to the chest wall or the whole breast RT. Coming to the next part of the presentation about the neoadjuvant scenario. In neoadjuvant scenario, whenever the node is positive, you start them on neoadjuvant chemo and you assess the patient whether the patient had good response to neoadjuvant chemo or not. If the patient has good response to chemotherapy, then you can take them for TAD. What I mean by TAD is targeted axillary dissection, which includes sentinel lymph node biopsy plus targeted lymph node biopsy. Targeted lymph node biopsy means you try to mark a node which is present prior to the surgery itself, prior to the initiation of chemotherapy, and try to remove that metastatic lymph node so that you can remove the axillary nodes and the sentinel lymph nodes. So when you do a TAD and the lymph nodes are negative, then that is a group of patients where you can avoid, where you can give RT. There is a question whether we can avoid RT. But when there is nodes are positive in the TAD specimen, definitely they would require lymph node dissection. Okay. So coming to this part where clinically N0 but pathologically clinically N1 and pathologically N0 after neoadjuvant chemotherapy, we have evidences from NSFDP 18 and 27. So what they say was in this trial was, even though the patients are clinically N plus to start with, if they are N0 at the time of post neoadjuvant chemotherapy, the relative risk of local regional recurrence is very less. It is around 5 to 8%. So when there is N1, definitely we should consider RT. And if this N0, there is some chances that some patients we could avoid when they fall in the low risk category. So the patients, if they are node positive, then definitely they should go for lymph node dissection. So the evidence comes from the same trial where you can find that if there is N plus clinically and N plus even pathologically after the neoadjuvant chemo, the relative the local regional recurrence rates in the range of 20% or high. So then definitely this patient should get RT. So while treating in the neoadjuvant scenario, what are the principles we need to understand is this low risk targets, they get the primary dose. That is either you give a 50 gray in 25 fractions or a 40 gray in 15 fractions. When there is very high risk target, then you have to give an additional boost of 10 gray in 5 fractions. Every node which are initially involved that have responded to chemotherapy would get 60 gray. And if there is some disease which is still present, you need to understand that this disease is resistant to chemotherapy. So these tumors will also be resistant. So they'll be also resistant to radiation also. So what we need to understand is if they are YPN0 after neoadjuvant chemo in the post-mastectomy tumor, we don't have any target. So we might need to just include level 1 and level 2 nodes. But if the axillary management is not similar to the protocol, as mentioned earlier, that is the patient has node positive, but no lymph node dissection is done, but no TAD is done, or in the patient's TAD there is significant nodal disease, we might need to consider inclusion of axilla into the treatment portal, and you might need to combine the images of the previous pre-chemo treatment images onto the planning scan to ensure where the and need to undissected axilla into the treatment portal. Sometimes we might also need to end by giving a boost to the tumor bed also. So to conclude, based on the Z11 study, sentinel lymph node biopsy in patients with node positive, you try to use high tangents, and you can also use regional nodal irradiation based on risk stratification. If the patient doesn't fulfill the Z011 trial inclusion criteria, you should go by the treatment algorithm which are standardly kept in. In neoadjuvant scenario, if clinically node positive, post neoadjuvant chemo YPN0, then you can treat only the chest wall and the breast, and you can omit the nodal irradiation in the lowest risk group. And if it is post dissection, if the nodes are still present, you need to treat. You need to either do axillary lymph node dissection and breast wall RT along with regional nodal irradiation. I think this is the last slide. Thank you.
Hello.
Sir, we can hear you, sir.
Thank you, Dr. Rajesh. You have clearly explained the importance of targeted axillary radiation. All other colleagues have understood really what we should do, because axilla is one of the important areas difficult to manage. And we have seen already left limb, upper arm edema and all other complications since years together. And also these surgical things management, neoadjuvant chemotherapy have come into play in the last a decade and a half. Like as I said, SLNB and neoadjuvant CT, they've all come just in a decade and a half. So we need to adopt the radiation according to the treatment what they have taken. And it's very clearly said now when we should treat, and he has also mentioned in a very simple way. So you need not use any fantastic techniques here. Just take the tangential border 2 centimeter upward. That's all. So that would include level 3, most of level 3, level 4 everything. So axillary management is responsible. Earlier it was responsible by radiation alone, and he is to take the blame also for arm edema. Now it is the responsibility of all of us, because SLNB and neoadjuvant CT. So they have made their patients' lives also better. So accordingly, we can't follow the same radiation 55 gray delivered to axilla and things like that. So in that way, I think these two things are practice change. From Monday onwards, we should do that. High tangential axillary radiation. So thank you, Dr. Rajesh. Thank you, Dr. Srinivas, for giving us the opportunity. It's a very nice piece of information, and every practicing oncologist should be aware of these two studies. Thank you.
Thank you, sir.
Thank you, sir. I thank Dr. Rajesh for his excellent presentation, and I thank Dr. Vishwesharaya for that very valuable input. Now I think we'll move on to the next session. I welcome Dr. Somsekhar, who is a senior most consultant surgical oncologist and chairman for Manipal Oncology Group. I welcome you, sir. Good evening, sir. So Dr. Somsekhar will be talking on axillary management after NACT and what is the optimal axillary management for early stage clinical node-negative disease. Over to you, sir.
Thank you very much. At the outset, I'm very proud, Srini. I saw him since he's a small kid, and seeing him grow so much, becoming not just excelling as a good clinician and doctor, but more so as a very good human being and doing such a great event. Superb. In this time when you do a online meet, there are only 5 faculty. Seeing 100 people at this end of the day in a midweek, superb. That shows great about your organization skill, your affinity, and all the well-wishers like Shekhar Patil, all senior people, Vishwesharaya, everybody who has joined here. I'm so proud of it, and I really, my heartfelt wish you succeed more and more. It's not easy to organize such an event, coordinating everybody, identifying who is good in which topic, getting the slides, making sure they reach. Superb. And the way it is running, it is hats off to you. I'm extremely happy and proud. My heart is swelling, knowing you very well from kid, and superb. And my wishes that you excel more and more in life, more than this. Thank you very much.
Thank you so much, sir. Thank you so much.
Thank you. So what I am going to do is, actually, it's good that we had a topic before this, which is very much close to, there are 2 abstract. What I did is I sort of clubbed the slides of both, so there is no repetition to give in nutshell. What is this? This is a topic which is very close to me. I authored a very big, a chapter recently, how to manage axilla in new era. SLNB positive, does it mean automatic ALND, or is there a scope of no ALND? Is radiation to axilla mandatory when sentinel node is positive? So I authored a very big chapter and also published in IJSO a big article right now. A lot of my work are in this. We analyzed our 12,000 sentinel node over last 15 years with follow-up at our hospital, and the isolated axillary recurrence in SLNB group was 0.2% in Indian patient. That go on to say that how safe SLNB is. So there are 2 abstract I've clubbed together. How do we manage axilla in the era of neoadjuvant? Remember, when we say SLNB in N0, most of this is for upfront cases. People are apprehensive when you give chemo. Is it okay? Is false negative rate fine or not? So the first abstract is the optimal axillary management in early N0. Remember, there are 2 most important things when you do SLNB. Number 1, what is the technique? Single dye versus dual technique of ICG versus hot technetium, or isolated ICG with blue dye and technetium. Number 2, identification rate should be more than 96% in any institution to do whichever technique you follow. Number 2, the false negative rate as per the ASCO and CAP guidelines, College of American Pathologists, should be less than 5%. Having said that, most of the institutions have a false negative rate, FNR, of around 3.5%, which is very, very important. If the FNR rate is more than 5%, it is not acceptable. Third guideline by ASCO and CAP, any institution who starts sentinel node, the surgeon, the pathologist, nuclear medicine guy, and the technician team should do 20 cases and do axillary clearance as a validation, and identification rate should be more than 96%, and their FNR rate should be less than 5% to do. These are the 3 guidelines to do. Now we want to see, does that apply to post-neoadjuvant chemo? Now, initially, when I was doing oncology, we thought axillary stage, axilla has got a therapeutic benefit. For every 4 axillary recurrence that is prevented in low risk, 1 life saved. For every 2 recurrence saved, one life is saved if it is high risk. But now we understood that gone are the days where the primary systemic therapy, you want to use Taxol or you want to use anthracycline, is no longer based on axilla, but on the profile of the primary tumor. More so much so that except classical luminal A, almost everybody ends up with chemo. No longer taxanes are analyzed and planned based on the node, which means primary medical oncology treatment is going to continue whatever it is. That leaves only surgeon and radiation to tailor make. So is axillary, clearance therapeutic or staging? Now in this modern era, it is essentially becoming only staging rather than therapeutic. Now, second issue, if we believe that it is not therapeutic because systemic therapy has a good impact on both locoregional recurrence and overall survival, then is there an impact on local recurrence? This was proved by Umberno-Vernotis trial, which showed that if you lose 5 mistakes in axilla, that is FNR, false negative rate is 5%, all 5 axillary, you leave disease in 5 out of 100 and come out, still axillary recurrence is not 5%, but it is less than 1%, which shows systemic therapy in itself has an impact on that, which is the concept of the stem cell therapy came, which means in this modern era, isolated axillary recurrence is less than 0.2%. So should we really do axillary dissection even when it is N0? The whole issue is mastectomy doesn't have much morbidity other than psychological and cosmetic, but it is the axilla which causes the survival problem and many quality of life issues. So even though gold standard is axillary clearance, the standard of care is SLNB. So the MRI is not a good technique nor a PET scan to assess the node in breast. So don't say PET scan done negative, so it is negative. No. MRI done, there's no suspicious node. No. Only high frequency ultrasound of axilla as per the sounds trial criteria is closest to assess, but the gold standard is SLNB. So now it is proved that no matter which technique you use, blue dye, combination of blue, ICG alone, all are same. Second thing, where you inject, retroareolar, intratumoral, peritumoral, all are same. Now we have phenomenal trials of large number, which shows in a T1, T2, T3, clinically ultrasound N0 axilla, it is crime not to offer SLNB. And if you do SLNB, the axillary recurrence overall survival is not compromised than ALND, but patients accumulate lots and lots and lots and lots of morbidity, which is very, very sad. Now, the other thing which came is whether to do sentinel node before or after. That is where the NSABP trial, Sentinel trial came, where now it is accepted that when you use NSCT, you should do ultrasound of axilla, suspicious node you core, clip it, and later you should do SLNB after the NSCT with removing the targeted axillary node because 60% of positive nodes are sterilized. This is the summary of the first abstract. SLNB in N0 is mandatory, crime not to offer. Even if sentinel node is positive, low axillary burden, if you're doing a breast conservation, like Asacos Z11, no need to do ALND. You can just give an RT and tangential beam. No compromise in the survival benefit, also locoregional recurrence. If it is micrometastasis in SLNB, no need to go back. Macroscopic metastasis, low axillary burden, no need to do ALND. Macroscopic metastasis with more than 4 node high risk burden, you have an option of doing ALND or Amaros trial axillary RT, that is superior to ALND because then the lymphedema is low. And omitting SLNB in selected patient in elderly is acceptable. Now the abstract 2. In this, they wanted to know after giving neoadjuvant chemo, if it was N0 before, how to manage axilla. If it was N plus, how to manage, and this is the point. So, these are the term for non-surgeons. SLNB is sentinel lymph node. ALND is complete axillary clearance. ARM is reverse axillary mapping because there is a separate lymph node draining the arm, separate for breast. Even if you have to do a lymph axillary clearance, preserve the node from the arm, reverse axillary mapping, and then you can avoid lymphedema. Then targeted lymph node biopsy, targeted axillary clearances. So sentinel node, ALND, TLNB is targeted lymph node biopsy. You mark the node before starting chemo positive and then you remove it with a clip. Or MLND, which is also called a marked lymph node, targeted axillary dissection means SLNB plus targeted lymph node biopsy. So it is basically SLNB plus TLNB. So these slides have been showed by many, but I'm showing as a surgeon. One thing is very clear. First algorithm, clinically N0, ultrasound axilla N0, T1, T2, T3, SLNB, node negative, no further clearance, node positive, low axillary burden, BCT, no ALND required. Now node positive. If it is node positive in a neoadjuvant group, if there is a good response, Rcb index is 0 or 1, then you don't have to do ALND. You can do targeted axillary dissection, node negative, you just go ahead and do radiation. If it is positive, you have an option of doing ALND. Now, if it is a RCB 2 and 3, that is a suboptimal response, those patients will have 40% positive node, then you do a axillary clearance. So N0, very clear. N plus, assess the RCB of the response clinically and this, and then you tailor make the whole thing. Now I'll take one by one what it is. What do we mean? Now, what percentage of patients, even after SL, people are afraid, oh, if you give chemo, lymphatics are blocked, can we identify node? You'll be surprised to know what is the incidence. 95% of the time, even after chemo, you can identify the SLNB. So first issue is sorted out. Which trial? MD Anderson trial, Ganiac 2 trial showed 97% of the time, even after chemo, lymphatic are patent, you can do a clearance. So first issue is sorted out. Second issue, what is the false negative rate? Remember what the ASCO and CAP guideline, less than 5%. The NSABP told 10% FNR, but the new MD Anderson trial says 5.5. So can you directly do it? Here comes the targeting. If there is a ultrasound of the axilla before starting chemo and you find it is positive, if you can clip that node along with the breast lump and then you do a targeted axillary retrieval, then the false negative rate, even in that particular group, as per the 4 trial, Elena trial, Risas trial, Centa trial, and MD Anderson, false negative rate are 2, 3, 4. So what is the golden value? Less than 5%. Look at this now. Now, with a targeted axillary clipping, as per the 4 trial, FNR rate has come below 5%, which means it is acceptable to do. So that says the importance of the new guideline from the American College of Surgeons and NCCN 2022 and Early Breast Cancer ESMO, which says even after neoadjuvant, as long as you have done axilla ultrasound and clip the node and remove that, it is still acceptable and equivalent to do it. So second thing, people say, oh, how often can you clip the node and how often is that sentinel node? You'll be surprised. 65 to 81% of the time, the clip node is sentinel node as per the 7 trials. So second issue also sorted out. What is the first issue? After NACT, 96% identification rate. Superb. After clipping the node and target axillary clearance, false negative rate less than 5, 6 trial. How often is the clip node and SLNB same? 60 to 70%. So this next, if you clipped a node, how easy to retrieve? People say very tough to identify. Look at the trial. It says that 87% of the time you can remove that. So the 4 part is clear. Fifth, what can you use? There are 12 markers. You can use a clip, you can use a dye, you can use a wire, you can use a radioiodine seed, you can tattoo it, you can use a savvy, you can use a magnet. Doesn't matter. All of them are quite good where 96% of the time you can retrieve. So this issue is sorted out. Now you have done the clipping and you have found it. If there is a good response to neoadjuvant, especially you know that if a patient is HER2 positive, neoadjuvant dual marker you used, or if it is a TNBC, you added a cisplatin, carboplatin, response is very good, then axillary targeted clearance you can do, and even if the node is positive, no need for ALND. So this is the trial which is pending, NSABP B51, which is going on in association with RTOG 1304, where if the node is positive, instead of doing ALND, if you give external beam RT, it can be okay to omit that particular node. Now comes the issue. This is if there is a micrometastasis after neoadjuvant in the SLNB, does it mean ALND? As per current guideline, any residual disease in the axillary node, If you are not following the Amaros protocol and giving dedicated RT to axilla, you need to do ALND. But this alliance trial is no ALND versus ALND, which is pending, which is going to come back. Now the other issue. What is the other issue? Other issue is if there is a suboptimal response, what should we do to this particular area? That is the only issue, because then the nodal burden is very high. That is where the alliance trial says that you can do reverse axillary mapping, keep the lymph node coming from the arm, preserve that node, go ahead and do ALND or do a primary LVA. We now in my hospital, we do SLNB, frozen, negative, no ALND, positive. If I do ALND, then I immediately do a primary lymphovenous anastomosis with ICG. So there is no lymphedema that develops in this particular patients. So in conclusion of the two abstract, T1, T2, T3, N0, ultrasound axilla N0, crime not to do SLNB, clear. Whichever technique you use, ICG isolated dual, same. Site of injection doesn't matter. If it is a neoadjuvant chemo, yes, you can do SLNB. Identification rate is still more than 98%. Targeted axillary clearance, if you do, still FNR is less than 5%. SLNB positive micrometastasis, no ALND required. SLNB positive macrometastasis, low axillary burden, no ALND, no targeted RT to axilla, tangential beam is enough. Macrometastasis, high axillary burden, ALND or dedicated RT to axilla. And then if it is a good response, no ALND, no RT to axilla, patchy response, ALND with RT. So consider targeted axillary clearance, and it is a very high level evidence now to do this. Thank you very much.
I thank you very much, sir, for that excellent presentation. You are doing such a great work in your hospital that we can all witness it. Thank you very much for that excellent presentations.
Thank you. Thank you.
We'll move on to the next session. I welcome Dr. Avinash for the next presentation. Avinash is a consultant, senior consultant medical oncologist in Clear Medi Radiant Hospital in Mysore. This session will be chaired by Dr. Rajiv. Dr. Rajiv, are you there? Dr. Rajiv, Associate Professor from
Yes, Srinivas.
Dr. Avinash.
Yeah, good evening, all of you. So am I audible?
Yes, Avinash, you're audible.
Yes, okay. At the outset, I'll thank Dr. Srinivas for allowing me to be a part of this wonderful meeting. So today I've been asked to talk about two important trials with respect to endocrine therapy as an adjuvant in breast cancer. One is in premenopausal, the other one is in postmenopausal. Sorry, my slides are visible?
No, sir, not yet.
So I think you have to stop sharing, otherwise I cannot share the slides.
Can you do something there? Dr. Avinash is not able to share his screen.
So now he can, I think.
Avinash,
yeah.
Right now.
Yeah. The major two trials are the actually updated data of two trials. One is the Astra trial and the other is from the denosumab. The first trial is
Avinash, sorry to bother you. Still, it's not visible. Did you share your screen?
Yeah.
Ekta, are you able to see Dr. Avinash's screen? Because I'm not able to see the screen.
I'm able to see the screen, but slide you need to show, sir.
Yeah, that's what.
Not visible?
Avinash,
yes, sir, your slides are not visible.
Once again, I'll try to do it again.
Stop it and redo it.
Just a second.
Yes, sir.
Yeah, is it visible now?
Yes, sir. Yes, sir. Yes.
Okay.
We just need to make it full screen.
Yeah.
Yes.
Okay. So The first trial is the updated data of Astra Trial. This is basically the usage of, sorry, I'm think the same problem with Dr. Mangesh. I'm not able to see the first the heading. Anyway, okay. This is the Astra trial. This is actually usage of ovarian function suppression along with the tamoxifen in hormone-sensitive breast cancer who remain premenopausal or resume menstruation after chemotherapy. Actually, this is the Korean breast cancer study group 05 trial, the 8-year follow-up trial. We already know that there is a clear survival benefit of breast cancer events from addition of ovarian function suppression to tamoxifen who remain premenopausal after chemotherapy based on 2 major trials of soft and text. And when we see the soft trial, there is a good data of 5-year DFS and 8-year DFS with a good hazard ratio. We have also the 12-year DRFI data also. All these days we had a 5-year DFS hazard ratio of 0.69. So this was the data which was available from the JCO 2019 published data. And this is the Astra study design. The inclusion criteria were obviously premenopausal women less than or equal to 45, hormone receptor stage 1 to 3 primary breast cancer who had been treated with surgery and chemotherapy. So here the major difference between the soft text trial and this trial, soft and text, and along with this Astra trial is the ovarian function evaluation. So the ovarian function evaluation was done every 6 monthly for 2 years, and the serum FSH level was calculated. And if patient had amenorrhea for 2 years, so they were excluded from the final analysis, survival analysis. They were labeled as permanent menopause group. And the patients were randomized into tamoxifen with gozerelin with tamoxifen alone. The primary endpoints for disease-free survival, secondary endpoint was overall survival. So this is the difference between other 2 major trials and Astra trial. So here if patient had chemotherapy-induced amenorrhea, the only tamoxifen was continued with the ovarian function evaluation every 6 monthly for 2 years. At the end of 2 years, if the patient had the menopause, they were excluded. And those who had regained menstruation, they were randomly assigned into tamoxifen with ovarian function into 2 groups. And if the patient had premenopausal from the beginning, after 3 months after last cycle of chemotherapy, they were randomized into tamoxifen and tamoxifen with ovarian function suppression. So this is the overall consort diagram where the intent to treat population were 647 in tamoxifen group and tamoxifen with ovarian suppression were 635. The total number of the people the available were 1,282. These are some clinico-pathological features. The median age was 40 years, and as you can see, a significant number belong to high-risk patients, that is lymph node positivity of around 55%, and HER2 expression was seen in 14%. So that you can almost compare with the soft trial, where the lymph node positivity of 57%, median age of similar to the Astra trial, HER2 expression of the 19%. The difference, the major difference, what you can observe is the treatment duration of ovarian function suppression, which was only 2 years in Astra trial versus 5 years in soft and other text trial. So this is the post-trial follow-up study. This is a retrospective review of the prospective study. The data was collected for almost 6 months. So the primary endpoint was disease-free survival. Secondary endpoint was overall survival. Other unplanned analysis were done with respect to recurrence-free interval, breast cancer-free interval, distance metastasis-free survival, and local regional recurrence-free survival. The median follow-up of almost 106 months. This is the primary endpoint, disease-free survival, when the analyzed from time since enrollment. As you can see, there is significant benefit of almost 5.2% difference with respect to tamoxifen alone and tamoxifen with ovarian function suppression with hazard ratio of 0.67. This is again analyzed from time since random assignment. So this is again the hazard ratio of 0.67% with almost 6% absolute benefit in disease-free survival. So this is again sites of first disease-free survival events, almost 132 at 5 years and 232 at 8 years. As you can see, the contralateral breast cancer incidence was 0.8% in tamoxifen and 1.4% with tamoxifen with ovarian function suppression. And there were almost 17 other primary cancers versus 8 in tamoxifen overall with ovarian suppression. The sites of recurrence-free interval events, almost distant metastasis were seen in almost 12% versus 8.5% versus tamoxifen alone in almost 12.2%. Multiple areas of distant metastasis were seen in 4.3% in tamoxifen alone versus 1.9% in those patients who received ovarian function suppression. So you can see, as expected, tamoxifen alone group had almost 4 endometrial cancers and colorectal cancer of 3, and there were almost around 8 other second primary cancers in patients of tamoxifen with ovarian function suppression. When we see the overall survival, there is no much difference with p-value of 0.3, but there is some absolute benefit of almost 1.2% at the end of 8 years. So again, secondary endpoint, there is absolute benefit of almost 4% with respect to recurrence-free interval, breast cancer-free interval, and distant metastasis-free survival. The maximum survival outcome or the best survival outcome was seen in patients who were enrolled between almost 6 months. That is the time interval between enrollment and random assignment. And this is the randomization state by age at enrollment. As you can see again, the benefit was seen across all subgroups, but the maximum the subgroup benefited were the patients who had age of 40 to 45 years and HER2 negative status. So when we excluded patients who were lost to follow-up, the total number of patients were available for analysis were 1,231. As you can see, the disease-free survival hazard ratio of 0.66 and 0.67 with respect to DFS, and though there is no much difference of overall survival benefit. So to summarize, so almost this study demonstrated 5.2% absolute disease-free survival benefit with 2 years of ovarian function suppression added to tamoxifen compared to tamoxifen alone. And there was no difference in overall survival at the end of follow-up of 8 years. So what is the implication of this study? I think the updated data from the Astra Trial demonstrated a large benefit for 2 years of ovarian function suppression. And the limited duration of ovarian function suppression in selected patient may be optimal given the risk and side effects. So probably in our setup, the patients who receive ovarian function suppression for 5 years have financial implications. I think that is the one thing which we can come across, and we can selectively use only 2 years of ovarian function suppression in selected patients. Coming to the second study, which is again in postmenopausal, the use of denosumab along with aromatase inhibitors. This is the fracture reduction and survival results of almost more than 3,000 or nearly 3,500 patients in randomized double-blind placebo-controlled ABCSG 18 trial. So we know that the adjuvant endocrine therapy with aromatase inhibitors compromises bone health, especially in postmenopausal patients with hormone receptor breast cancer, which leads to increase in fracture incidence. And we been using the bisphosphonates to prevent that. And there is an evidence that adjuvant treatment with anti-rank ligand antibody denosumab counteracts these side effects and may improve outcomes with respect to skeletal-related events. So here is the report of long-term outcome of this trial. So this is again a placebo-controlled double-blind trial. So almost, as I told, 3,500 postmenopausal patients and hormone receptor positive who were receiving adjuvant non-steroidal aromatase inhibitor therapy, which were randomized into a placebo versus denosumab 60 milligrams subcutaneous every 6 monthly. So these were the endpoints. The primary endpoint was time to first clinical fracture. The secondary endpoint was percentage change in bone mineral density, the vertebral fracture, disease-free survival, bone metastasis-free survival, and overall survival. So as you can see, the clear-cut difference in the curves of placebo versus denosumab. Almost number of fractures were 92 versus 176 with hazard ratio of 0.50. So median follow-up of 8 years. Based on various models, they have done the survival analysis. And with respect to patient characteristics, the patients were matched with respect to T stage, N stage, grading, primary tumor histology, hormone receptor status, HER2/neu, whether patient received no chemo or adjuvant or neoadjuvant. So almost all characteristics were matched between the placebo and denosumab group. And based on the results, there were no new toxicities. And despite proactive study, as we know, denosumab had have a side effect of osteonecrosis of jaw, but in this particular study, there was no even a single positive ONJ. And there is one confirmed cases of atypical femur fracture, which is again known entity when we use denosumab. So this is the benefit of almost hazard ratio of 0.8%. Across all subgroups, as I mentioned, the age, T stage, N stage, histology, and whether the patient had neoadjuvant or adjuvant chemotherapy across all subgroups. This is again overall survival benefit of 0.8. So, and even when we see the exploratory analysis, the majority of events were distant recurrences in bone, liver, lungs. And the long-term BMD, when we analyzed the bone mineral density from the baseline to the last assessment, which was increased in denosumab group and it decreased in placebo. The trend for reduction of contralateral breast cancer, 24 versus 29. Reduction of second non-breast primary malignancies, 100 versus 127. So all this support the use of preventive denosumab. See, to conclude, the adjuvant denosumab 60 milligrams subcutaneously every 6 months during aromatase therapy is safe. And definitely it markedly reduces treatment-induced clinical fractures even in long term. And all the endpoints were improved in this descriptive final long-term analysis. So it should be considered for routine clinical use in postmenopausal patients. So what I can say in our routine practice is we can avoid hospitalization, we can avoid IV injections when we use bisphosphonates, and it is simple to administer every 6 monthly denosumab. Now with availability of generics, I think it can be easily affordable to many of our patients. Thank you.
Dr. Rajiv, expert opinion, please.
Yeah. Thank you, Srinivas, for giving this opportunity and nice presentation from Avinash. Regarding the Astra study, the preserving ovarian function in the young females is also important. Even though there is no overall survival benefit, DFS benefit is there. So short-term goserelin given to suppress the ovarian function has a benefit in DFS. Of course, you will not get overall survival if the number is small. So that is one important thing, and it was nicely presented by Avinash. And one thing I wanted to highlight was, is there any fertility data in the study that was not mentioned? So that is also one important. Coming to the second denosumab study, as he rightly pointed out, that is a doable thing in our country also. It is a 2 doses 6 monthly. So it is with the availability of generics also, it can be doable with the benefit also. And one caution here is, what is the data on rebound phenomena in the denosumab study? That was to be kept in mind. So otherwise, it is practically, it was important, and you can go ahead with the accepting the data and go ahead with the day-to-day real world treatment from tomorrow also. Thank you.
I thank Dr. Avinash for his excellent presentation, and I also thank Dr. Rajiv for that valuable input. We'll move on to next session. Antibody drug conjugates in HER overexpressing breast cancer, sponsored by Zydus. I welcome Dr. Linu Jacob, professor and head of the department, my teacher, to this session. Dr. Linu, sir.
Yeah,
Dr. Lino
Thanks.
is my teacher and he is my mentor and a very good friend who always wishes for my best. I thank you, sir, for this sharing this session. Now I welcome Dr. Prasad Narayan for delivering for the scientific presentation. There are 4 abstracts in this session in antibody drug conjugate in HR overexpressing breast cancer. I welcome Dr. Prasad Narayan, sir. Dr. Prasad Narayan, sir, are you there?
Good evening. At the outset, I would like to thank the organizers for this opportunity. So in the next 20 minutes, my job will be to discuss about antibody drug conjugates in HER2 overexpressing and also in HER2 not overexpressing breast cancer. So we will discuss 3 abstracts from ASCO and 1 data set from an Indian from the Indian context. So this is the Destiny 3 study, which was which has already changed the standard of care option in second-line treatment of metastatic breast cancer, which is a TDX versus TDM1 study. The abstract which I will be presenting will be the safety follow-up of the study. We all know this study, tremendous improvement in PFS as compared to TDM1 when trastuzumab deruxtecan is used, almost more than double of that. What we have now is the extended safety data. The median duration of treatment of trastuzumab deruxtecan was 16.1 months, and in TDM1 in the study 6.9. Obviously, because of the increased responses and decreased progression in the TDX arm, the patients have got this drug for a longer period of time in the study. So if you see the safety update overview, the rates of any grade 3 or 4 toxicity is similar. But the drug discontinuation rate, if you see, it is almost double in the TDX arm. So to see this, because the patients have got a longer duration of treatment, the exposure adjusted incidence rate was also published in this safety analysis. And if you see that, actually there is no difference in the TDX versus TDM1 in terms of the drug discontinuation or dose reduction when you compare the total duration of exposure of drug. So that is and what are these safety or the treatment related adverse events which were seen? If you see the trastuzumab deruxtecan side effects, almost similar to a chemotherapy kind of side effects, like the GI side effects, the neutropenia, alopecia is seen in almost 37, which is important because this is an anti-HER2 therapy, which we usually, when you give as a single agent, TDM1 hardly causes any alopecia. So those are the side effects which were seen with this. And the specific side effects and the time to onset of side effects also is slightly more higher in the TDX arm. And this is just a graphical representation of the of what we already discussed about the nausea, the vomiting, the fatigue, the alopecia, the nausea, vomiting, and alopecia being more in the TDX arm as compared to the TDM1 arm. And the prevalence of nausea, vomiting, almost like a chemotherapy drug is what we see in the trastuzumab deruxtecan with long-term follow-up. Fatigue was similar if you compare with TDM1, alopecia was more. Now, coming to the side effect which we are all bothered about when we talk about trastuzumab deruxtecan, the interstitial lung disease or the pneumonitis. When we saw the phase 1, phase 2 data of this drug, this was discussed in detail. But what we see with long-term follow-up of Destiny 3 is that the grade 4 toxicity is almost not there. The grade 3 toxicity is very less, 0.8% only, 2 patients out of 257. And most of the toxicities are grade 1, grade 2, which means that they can go ahead with the treatment with either a dose reduction and or a break of treatment. So that is very reassuring, actually, that the ILD doesn't seem to be a very high grade in TDX, despite when we have the long-term follow-up. So in conclusion, the safety signals, no new safety signals are demonstrated. It's a safe drug. It gives almost more than double the PFS. And I would say that if the drug is available, that should be the standard of care in patients who have progressed on one line of anti-HER2 therapy. So it reinforces the established favorable benefit risk profile of deruxtecan over TDM1 in HER2 positive metastatic breast cancer. We go to the next study, which is the blockbuster presentation of this ASCO. Lot of discussion after this. So this is a Destiny 4 study, which actually looked at a group of patients who are HER2, HER2 positive, low, HER2 low, that is IHC 1+ or IHC 2+ with FISH negative. We would say that almost 2/3 of the patients in our practice belong to this category. If you take the hormone receptor positive, HER2 negative and triple negative group and see how many of them were IHC 1+ or 2+ with FISH negative. So what is the outcome of this study? It actually adds another 50% of the patients who can be treated with a anti-HER2 directed therapy with trastuzumab deruxtecan. How we will see when we see this study in detail. So what is the standard of care in this group of patients now? If they are hormone positive, they go for endocrine therapy, they go for PARP inhibitors, they go for, if they're Germline BRCA positive. If they are hormone receptor negative, there is a role of PD-L1 inhibitors in this group now. BRCA, PARP inhibitors are also used, or chemotherapy. So the bottom line is that when a patient progresses after a CDK4/6 inhibitor, real world studies show that the PFS is less than 4 months in this group of patients. And similarly, when patients progress after eribulin and capecitabine, they provide only minimal benefit with a PFS of around 4 months after anthracycline taxane failure in triple negative disease. So definitely unmet clinical need. And trastuzumab deruxtecan, as we all know, has got a higher bystander effect. It has got a highly potent topoisomerase 1 inhibitor payload, and as depicted in the cartoon, we can see how the drug gets internalized, cleaved, and then releases the drug with lot of membrane permeable payload, resulting in bystander effect. So it's a much more potent drug, which in terms of the receptor target. And we have data from phase 1b in heavily pretreated patients. There was a PFS of 11.1 and a response rate of 37, which is more than 1/3 of the patients responding. Based on this, the Destiny 4 study was randomized, a bold study, 2:1 randomization to get the patient's therapeutic therapy, the physician's choice chemotherapy, which could be capecitabine, eribulin, gemcitabine, pacli or nab-pacli versus trastuzumab deruxtecan. Primary endpoint was PFS. And the overall survival was also a secondary endpoint in this study. There were 713 patients screened, 557 randomized, 2:1 randomization. And the baseline characteristics, it is well matched. Hormone receptor, if you take hormone receptor positive patients, or if you take all the patients, which include a percentage of the patients with triple negative, they are all well matched. And I would like to draw your attention to the fact that 75% of the patients, almost more than 70% in all the groups, had liver metastasis at baseline. And all the patients were ECOG 0 or 1. So number of prior therapies, if you see the list of patients getting chemotherapy in hormone positive disease was almost 1 line of chemotherapy in 60%, 2 lines in 37%. And this is more in if you take all patients, because that includes the triple negative patients as well. And endocrine therapy also, there were patients, almost 70% of the patients had received 2 lines of endocrine therapy, and some of them, 1/3 of them had received 3 lines of endocrine therapy. So heavily pre-treated patients, 70% of them exposed to CDK4/6 inhibitors as well. So what is the outcome? Again, a very impressive outcome in this study. If you take the hormone receptor positive, that was the primary group of patients who were included in the analysis. There was a median PFS of 10.1 versus 5.4 with highly statistically significant p-value and delta of 4.7 months. If you take all patients, also the hazard ratio is 0.5, 9.9 versus 5.1. So definitely the study meets the primary endpoint. The overall survival data, 23.9 months versus 17.5, again statistically significant with good hazard ratio, regardless of whether you take only the hormone receptor positive group or you take all patients. So the PFS and OS in hormone receptor negative, which is the lesser number of patients, the triple negative group in this, again it is significant. These patients did poorly when they were given the standard of care treatment, and addition of and when they were given trastuzumab deruxtecan, there is an improvement in outcome in both PFS and OS. What the subgroup analysis, we always want to see whether there is any particular subgroup which did not benefit or which did benefit more than others. There is nothing to choose here. Regardless of the usual suspects, the visceral disease, the performance status, the race, age, prior lines of treatment, all the patients seem to benefit by the addition of trastuzumab deruxtecan in this group of patients. Response rate 52.6 versus 16 and 50% versus 16.7 in the hormone receptor positive versus hormone receptor negative group. So definitely it improves all the usual parameters which we check to decide a change of practice. So 70% clinical benefit in the hormone receptor positive group and 62% in the hormone receptor negative group. So these are the best change in the target lesions if you take all patients, or if you take the hormone receptor positive patients separately. And as we saw in the Destiny 3 trial, the side effect profile, mostly like chemotherapy related side effects, the GI side effects and the neutropenia or thrombocytopenia were more seen in the trastuzumab deruxtecan group. Overall safety summary, it is a safe drug. The drug dose discontinuations were 16% in this group, and similar to the previous study, it is as compared to standard chemotherapy, since the patients got more exposure, maybe that could have been the reason for more percentage dose discontinuations there. The grade 3-4 side effects are, there is nothing to say that this is more than the standard arm here. Median treatment duration was 8.2 in the deruxtecan arm versus 3.5 in the other arm. So on treatment death 3.8 versus 4.7%. And even the neutropenia was more on the control arm because that was standard chemotherapy arm. Adverse events of special interest, the ILD, again, not very significant, more than the grade 1 and grade 2. Left ventricular dysfunction also, there is nothing much to say. So overall, it's a safe drug. It establishes the new standard of care in HER2 low group, the first HER2 therapy to demonstrate this kind of statistically significant and clinically meaningful improvement in PFS and OS versus the standard therapy. So that is about the HER2 inhibition. Now we go to HER3, which is an ongoing, a drug in development, I would say. It's a dose escalation study, phase 1-2 study of another ADC called patritumab deruxtecan in this group of patients. And when you talk about this drug, this is almost similar in structure to the trastuzumab deruxtecan, and the key attributes, again, the payload mechanism and shorter systemic half-life, stable linker payload, so and the bystander anti-tumor effect. So HER3 is also expressed in almost 50% of the breast cancers, and it is associated usually with poor prognosis. So it's good that we are finding newer pattern of resistance of anti-HER2 therapy, and maybe we will be now using more of combination anti-HER2 therapy in future. So this is an update of the ongoing phase 1-2 study of this drug, and 3 cohorts are described. One is hormone receptor positive, HER2 negative, triple negative, and HER2 positive group. In this, the HER2 positive is very small number, and the dose escalation was from 4.8, 6.4, and 8. And what we have, the baseline characters, heavily pre-treated, very high volume disease. Most of the patients had lung or liver metastasis, and median number of prior cancer treatments could be as much as 2 to 13 actually, which is heavily pre-treated patients. And the primary reason for discontinuation of treatment was progressive disease, as is expected in this group of patients. So clinical activity, there was a response rate in almost 30% of the patients with hormone receptor positive group, in TNBC almost 22.6%, and in HER2 positive almost 43%, which is significant. These are the kind of numbers which we saw with the trastuzumab deruxtecan in the earlier studies. So another drug in the anti-HER2 therapy, targeting a new the target, which is the HER3. So durable anti-tumor activity across breast cancer subtype. These are the change in tumor size, which is meaningful in this group of patients, especially when they are heavily pre-treated. And overall safety profile, reasonably good safety profile, low rate of treatment discontinuation, which is 9.9%. We are still to get the long-term data of this drug. 6.6% again had the ILD, which seems to be a class effect of these drugs. similar in the group of 4.8 versus 6.4. And the side effects, as in trastuzumab deruxtecan, that neutropenia and leukopenia were seen more with this drug actually. So in conclusion, it demonstrated clinically meaningful and durable anti-tumor activity in a new target, that is HER3, safety manageable, and encouraging evidence of anti-tumor efficacy and manageable safety profile. We will see more studies of this drug for sure. Now, coming to the last part of the talk, that is to discuss, this is like a Sunday discussion of medical oncology and a Monday practice. So mostly what we discuss on Sunday, we don't have that in our hand on Monday, but we have a drug, the TDM1, which used to be beyond most of the of our patients because of the cost. Now we have an Indian drug, which is anti-TDM1. So let us see the Indian perspective on this. This is the US FDA approval of the 8 anti-HER2 targeted agents. TDM1 was approved as early as 2013. But large number of patients were not able to access it, and biosimilar development has led us with a new TDM1 biosimilar getting approval. The approval is both in the early breast cancer as an escalation for those who don't have a pathological CR, and also in metastatic breast cancer who have treated with trastuzumab and taxane separately or in combination. So it got approval in December 2020 and is being used in the clinic since May 2021. So this was the comparison of the efficacy, safety, and pharmacokinetic and immunogenicity of Ujvira, the TDM1. That's the name of the brand name of the TDM1 from the Indian company, with Kadcyla, which is the innovator brand. And there were 168 patients. The efficacy, safety, pharmacokinetics, and anti-drug antibody levels was similar. 37.7 was the response rate versus 33.3 in the Kadcyla group. And it met the non-inferiority margin and got the DCGI approval for the same. With that, we can see that by the launch of this drug in May 2021, from a less than 5% access to this drug in last 7 years, more than 20% access has happened, and more than 2,000 patients have been enrolled in this drug, have got the benefit of the drug in the last 1 year, which is significant and good for us because we can treat more patients with anti-HER2 therapy with good effect actually. So major enrollment initially, as expected, the physicians have used it in metastatic breast cancer, and now there is a shift towards enrollment in early breast cancer. So this is the recommendation. So we all know the recommendation of using adagrasib, which is the TDM1, the indications in early as well as late metastatic breast cancer. And those who don't have a pathological CR, the treatment escalation with TDM1 is being done now more frequently by us because of the availability of the drug. And since trastuzumab deruxtecan is not available for us, we still use second line as TDM1, and I think it will continue for some time. That's all from my side. Thank you, and happy to take any questions.
Yeah, thank you. Thank you, Dr. Prasad. So before that, good evening to all. Thank you, Dr. Srinivas, for giving me this opportunity. Congratulations to you for organizing this obviously a wonderful and successful meeting. So, and kudos to you for single-handedly steering it.
Thank you, sir.
So thanks to Dr. Prasad as well for very clearly conveying the take-home points. So always a pleasure to listen to him. So what we heard in the last 20-25 minutes or so was 3 abstracts in the HER setting. I would not tell, we usually tell it is HER2 setting. So I think we have to, hereafter in all the conferences, probably we'll have to rename it as the HER subgroup of breast cancer patients. As you would have seen, we dealt with HER2 overexpressed patients, low HER2 overexpression, as well as the HER3 overexpressed patients. So as far as the first study, that is the Destiny Breast 3 study, it's already a drug which is approved in the second line setting, but not available for us for use in India. So very clear advantage for the trastuzumab deruxtecan over TDM1, in fact, a doubling of PFS. So always when the superiority as far as efficacy is concerned, we always look at the toxicity aspect, and that is what the abstract was all about, looking at the long-term safety. And what was seen was that there were no new safety signals in the trastuzumab deruxtecan. As far as the second study, the trastuzumab deruxtecan in the HER2 low MBC patients, definitely seems to be practice changing, really excited. But again, we'll have to wait for the drug to be available in India for its use. So provides an additional treatment option for approximately 50% of the current HER2 negative patients whom we brand as HER2 negative based on the IHC or the FISH. And another 50% of the patients would benefit from or they will fall into the so-called HER2 low patients. So very impressive efficacy, in fact, doubling of the PFS and 4 times better overall survival. And both in the endocrine refractory as well as in the triple negative breast cancer. And as far as the third study is concerned, again, the patritumab deruxtecan, where we see that HER3 is emerging as an additional target in breast cancer, and that too in 30 to 50% of the patients. So again, as Prasad told, good and impressive anti-tumor activity in all the breast cancer subgroups, and with a similar safety profile, I would say, to the trastuzumab deruxtecan. Of course, it's only a phase 1/2 study, and we'll have to wait for phase 3 trial outcomes. So with that, I end my comments. Thank you so much. Once again, congratulations to Dr. Srinivas, and thank you to Dr. Prasad.
That's a excellent presentation by Dr. Prasad Narayan. I thank him very much. And I can't thank enough Dr. Lino for many inputs. Past 1 month, I'm chasing him just to chase the good abstracts, how to put it. And I'm just taking his opinions every evening. Thank you so much, sir, for that excellent opinion and very valuable scientific input. Thank you very much, sir. So now we'll move on to the next session. Newer formulations in anti-HER2 treatment in HER2 positive breast cancer. This is sponsored by Roche. A new formulation by Dr. Roshni Dasgupta. Dr. Roshni Dasgupta, are you there?
Yes. Good evening, Dr. Srinivas. Good evening, everyone. And
Dr.
definitely
Roshni is a consultant medical oncologist in our HCG Bangalore. Over to you, Dr. Roshni.
Thank you. I believe this is an excellent platform with a lot of knowledge sharing and brainstorming. And I would contribute a little to this new formulation which has come up for dual HER2 blockade therapy with trastuzumab and pertuzumab. So I'll just share my screen. I hope my screen is visible.
Yeah, your screen is visible.
Yeah, visible.
Thank you. Okay, this is the transforming journey for our HER2 positive breast cancer patient, where from IV formulation now we are slowly shifting towards the subcutaneous formulation with pertuzumab and trastuzumab. So these are my disclaimers. So to begin with, we are quite aware that as to what is the efficacy of dual HER2 blockade in both in all the 3 settings of neoadjuvant, adjuvant, as well as metastatic. So the neoadjuvant studies in the neosphere as well as Triphynia Bernice and the Peony study, it has shown that dual HER2 blockade with trastuzumab and pertuzumab in early breast cancer achieves higher pathological complete remission in the range of 49% as compared to a single HER2 blockade with trastuzumab of 31%. Similarly, in adjuvant setting for specific patient with a tumor size of 2 or more centimeter and nodal positive disease, adding pertuzumab to hertuzumab in the adjuvant setting increases the DFS as well as DFS survival of the patients. In metastatic, the landmark study Cleopatra, which showed that addition of pertuzumab to hertuzumab and chemotherapy, the median PFS increased by 6 months as well as median OS increased by 16 months. These results were also similar in other metastatic studies like the PERUSE and the PUFFING. So it has been very well established till now that Perjeta, which is pertuzumab, Herceptin, and chemotherapy, has benefit in HER2 positive breast cancer in different settings and has become the standard of care at present. This is the known algorithm. We all know about how HER2 positive breast cancers, early breast cancers, are treated currently, wherein all T2 above tumors are given neoadjuvant chemotherapy with HER2 blockade, either single or double, followed by surgery. Based on the complete remission or residual disease, the adjuvant is decided. In T1C, up to T1C node negative disease, surgery can be done in the beginning. Based on nodal positivity, again, further chemotherapy is decided. The chemotherapy backbone is usually preferred as only paclitaxel for node negative disease, whereas the standard TCH regimen for the node positive. So coming to this particular formulation, it's a fixed dose formulation of pertuzumab and trastuzumab, and it has been compared to the IV formulations. So currently the IV formulation which we are commonly using is well established, but there are certain challenges which comes into consideration when considering patient and healthcare system that already exist in our country. So long infusion and observation time. So loading and maintenance dose takes around 60 minutes and 30 minutes respectively for pertuzumab, whereas for trastuzumab that is 90 minutes and 30 minutes, which is followed by at least 1 hour or 2 to 6 hours of observation period for infusion related reactions. There is also challenge of improving resource utilization. The IV preparation times takes longer than the subcutaneous formulations which are already provided as a fixed dose formulation and requires less resources. It doesn't require subcutaneous IV pertuzumab, trastuzumab, as we all know, requires an IV access, be it a central line or a peripheral line. Given a peripheral line becomes difficult to be found in patients who have already receiving chemotherapy, and central line are associated with risk of infection, thrombosis, and discomfort. So FESGO is one of those formulations. It is the first formulation in oncology which has combined two monoclonal antibodies, pertuzumab and trastuzumab, in a single vial for subcutaneous injection. It contains the same antibodies, the same drugs, pertuzumab, trastuzumab, but the administration is subcutaneous. To this particular combination is the recombinant human hyaluronidase, which allows large dosages of the drug to be administered subcutaneously. It is available in a ready-to-use fixed-dose formulation, does not require any mixing, and it is administered by subcutaneous and takes 5 to 8 minutes depending upon whether it is a maintenance or a loading dose. The mechanism of this particular formulation lies in the fact that it has an enzyme called hyaluronidase, and it is an endoglycosidase which causes increased dispersion and absorption of the co-administered drug subcutaneously. It breaks down one of the layers known as the hyaluron in the subcutaneous tissue and creates space enough to accommodate the 10 ml or 15 ml of drug that is administered. This effect of hyaluronidase is reversible, and the permeability of the subcutaneous tissue is again restored within 24 to 48 hours of administration. And we all know the mechanism of trastuzumab and pertuzumab, given the fact that trastuzumab, apart from ADCC, prevents homodimerization of HER2, and pertuzumab acts at a different domain to prevent heterodimerization with HER2 and HER3. So with recombinant formulation, hyaluronidase used in the subcutaneous injection, as I described in this pictorial description, this is how the subcutaneous collagen macromolecules and elastins are not changed, but the hyaluron layer is broken down by the hyaluronidase, which allows the large fluid administration. So in usual conventional subcutaneous injection, up to 1 ml of fluid can be injected, whereas with this particular combination which contains this hyaluronidase, 10 to 15 ml can be injected. This is in one of the patients which I pictorially shown that in different hands of the same patient. In a patient who was given a bolus injection of 10 ml of 10% of IgG solution before and after infusion, as compared to in patients who had this recombinant hyaluronidase enzyme, there was no swelling at all visible in the site of injection. So the question is, does Phesgo fixed dose combination, pertuzumab, hertuzumab fixed dose combination subcutaneous have the same pharmacokinetics, efficacy, and safety as the IV formulations. So there are a number of studies that have already been done from phase 1 to phase 3 to address this question. So to begin with phase 1B study, it has been shown it was in this was a dose finding study in which healthy male were administered different dosages, and it was ultimately decided that pertuzumab 1200 milligram and Herceptin of 600 milligram. By this time, the Herceptin subcutaneous formulation was also already available. So this was more of a dose finding study for pertuzumab, and it was found that the loading dose of 840 IV had similar pharmacokinetics for 1200 milligram pertuzumab given subcutaneously, and 420 was equal to that of 600 milligram given subcutaneously. So in summary of this phase 1B study was that the loading dose as again 1200 and 600 maintenance was equal to that of the IV 840 and 420 milligram of Perjeta. The dose finding process is used to find the subcutaneous dose of pertuzumab as similar to those used in already developed existing Herceptin as well as MabThera subcutaneous formulations. There were no new safety signals observed with the pertuzumab subcutaneous alone and when co-mixed with Herceptin and co-formulated with Herceptin. PK and safety results from this study supported further development of Phesgo, and hence in further studies, which included phase 3 Federica study, which was a non-inferiority study assessing the pharmacokinetic efficacy and safety of pertuzumab fixed dose combination subcutaneous versus the IV formulation. In this particular trial, as our standard of care, all HER2 positive early breast cancer patients were given the NACD with adriamycin-based 4 cycles followed by taxane. The HER2-directed therapy was randomized as to it was either Phesgo or the IV formulation, followed by surgery. The primary endpoint of this study was a non-inferiority of cycle 7, P serum concentration, trough concentration. So in this particular finding, and before we start analyzing this particular graph, a few important pharmacokinetic informations for bioequivalence to know is that the efficacy of the drug, the ultimate clinical outcome is associated with the C trough and not the C max. The C max is the maximum peak that the serum or the drug concentration in the serum that happens after the administration, be it IV or subcutaneous. So though the IV formulation had a higher C max, but as in the diagram, as in the graph, the C trough were actually a tad bit higher than that of the IV formulation. And the area under the curve, this provides the exposure information. Again, for IV and subcutaneous formulation, the AUC curves were actually similar and probably a little more than for subcutaneous formulation. So further analyzing and deep diving into this pharmacokinetics was, as per if we compare the two primary endpoints of C trough, we see it is a little bit higher, in fact, in subcutaneous, and so was in the secondary endpoint arm. Further, to analyze the pathological complete remission rate in the intention to treat population, all patients had similar pathological complete remission rate in the range of 59% for both IV as well as subcutaneous formulation. When this was further sub-analyzed as per the body mass index, it was seen that in normal and overweight patient, it was same for IV and subcutaneous pertuzumab, trastuzumab. However, in that of the underweight and obese, the Phesgo did not achieve the pathological complete remission rate as equal to that of or similar to that of the IV formulation. For the underweight population, this is probably a little skewed data because the number of patients are very few, 3 and 7. However, in obese, there are considerable number of patients, and probably we'll have to rethink if we are using it in obese patient. Here, obesity has been defined as a body mass index of more than 30. Coming to the safety profile of Phesgo, it was comparable to the IV formulation as per the grade. It were any adverse events, grade 3 serious adverse events, including death, all were similar in both the drug formulations. Considering the type and the most common side effects like alopecia, nausea, diarrhea, anemia, and asthenia, again, it was similar between the IV and the subcutaneous formulations. So there was no new safety signals. The cardiac dysfunction, hypersensitivity rates, all were similar in the both treatment arms. There was no meaningful difference in the cardiac safety. So in the primary cardiac event, which was heart failure with significant LV decline, again, it was not very meaningfully different, though numerically it was higher in the subcutaneous formulation. And secondary cardiac event, which included LV EF assessment in the initial and confirm by a second assessment, was again similar. And drop in LVEF by 10% or more to a level of less than 50% was again similar for both IV and subcutaneous formulation. So Phesgo showed non-inferior pharmacokinetics versus the IV formulation with comparable efficacy and safety. It has been non-inferior as when it came to determination of the C trough concentration. It was non-inferior when total pathological complete remission rate was calculated between these two arms. And the safety profile, again, no new safety signals, as well as the known adverse events were also similar in both the arms. So now coming to what did the patients have to tell? Did they prefer Phesgo over IV formulation? So this was addressed by one of the studies, which was the Francesca phase 2 study, wherein all patients were randomized and given IV and subcutaneous formulation respectively for first 3 cycles, and then a crossover was done, and they were given they were shifted to the other arm. So the primary endpoint was to assess the patient's preference. So this was the analysis done, and it was shown that all things considered, among all the patients, the preferred route of administration for the drug was subcutaneous. So 93% of the patient actually preferred Phesgo. And the main reason, as it was found, was less time in clinic and more comfortable during administration. So even after crossover, after 6 cycles, patients were given the choice to follow whether follow IV or subcutaneous formulation, and 87% of them chose to continue Phesgo. Among further decision whether a patient preferred, how satisfied they were with IV subcutaneous formulation, 88% of patients who received subcutaneous were satisfied or very satisfied, whereas IV patients were 68% were either satisfied or very satisfied. So further, majority of the what were the opinion of the healthcare professionals when which one did they prefer and what were their opinions when IV and subcutaneous was compared? So one factor was drug preparation room. It did not require, it was a fixed dose formulation, it did not require mixing. So 15 to 20 minutes, which is usually required for a mixing process, it requires only 5 minutes to draw the injection from the vial. And in the treatment room, the healthcare professional estimated patient time in the room was also reduced from a whopping 300 minutes to 50 minutes when IV was compared to subcutaneous during the loading dose. And administration time was also reduced from 150 minutes to only 7 to 8 minutes, depending upon, again, loading dose or maintenance dose. So majority, 88% of the healthcare professional thought Phesgo was the quickest. It required less resource usage, and there was less drug wastage also. Again, adverse events was studied in this study. There was no safety signals, new safety signals. Adverse event types were also similar among between the two arms. So 85% of the patient preferred Phesgo, 14% preferred IV. The main reason why Phesgo was preferred was less time in clinic, more comfortable during administration. And healthcare professional also assessed that marked time reduction in mixing as well as administration and required few resources henceforth. Now the practical consideration. So how is subcutaneous in this Phesgo subcutaneous formulation is to be administered? The administration is a fixed dose combination, and few of the precautions that are to be taken. First of all, the most important is this injection is subcutaneous but given only in the thigh area. It is not given in the abdomen. So it should not be split. It should be drawn into a single syringe and administered in the subcutaneous area. Each time, different site should be used. For 2 different cycles, the different thigh can be used. And the first Phesgo injection usually comes with a kit wherein there is a sheet with a cut area through which the injection can be administered, and it provides the necessary privacy to the patient also. So during administration, the skin, usual way of giving subcutaneous, the skin of the thigh has to be pinched up. The needle has to be kept at a 30° to the flat surface of the thigh and slowly injected. Because the solution is very thick, a little bit of extra pressure has to be given while the administration. So the nurse or the administrator has to be very comfortable while the person is administering this particular injection. If the patient develops any injection-related reaction, one should stop the further subcutaneous infusion, not pull out the needle, but wait for some time and observe the patient. So in this particular diagram, it has been shown that the loading dose, which is 15 ml, is given over 8 minutes, followed by an observation period of 30 minutes, whereas the maintenance dose, which is 10 ml, is given at over 5 minutes, and observation period is 15 minutes. Setting aside hospital space, giving privacy to the patient is important, and given that it is subcutaneous, it can be administered in outpatient setting, but if it is being administered in chemotherapy day unit, proper blanket and proper privacy has to be provided. So what could Phesgo mean for patients and healthcare professionals? To summarize, it has a shorter administration time as well as observation time. Patient is in the hospital for a maximum of 30 minutes, for 40 minutes in case of loading dose, and for a maximum of 20 minutes in case of maintenance dose. It reduces the burden on hospital professionals also, like nurses and clinical pharmacologists, because it comes in a fixed dose formulation. This is because there is reduced time required for drug preparation. There are no new safety signals. It is as safe as the IV formulation, which we are very comfortable to use. Phesgo is the first formulation in oncology, again, is as a combination of pertuzumab and hertuzumab, and offers a faster and less invasive method for administration of the same. Studies have been done, phase 1A from 1B, 2 as well as 3, to show the pharmacokinetics are similar for the dose decided for subcutaneous and IV formulation, and so are the total pathological complete remission rate in intention to treat population. Majority of the patients preferred subcutaneous injections, and they have given the opinion that it did not impact their speaking time with the healthcare professional. So does the healthcare professional. 80 to 89% prefer subcutaneous injection because of time and resource saving. So Phesgo right now is FDA as well as EMA approved for the same indication as it is there for the IV formulation in HER2-positive early breast cancer, metastatic breast cancer with or without concomitant IV chemotherapy. Thank you, and I would conclude my study presentation. Dr. Srinivas, over to you.
Thanks, Dr. Roshni. That is a very excellent presentation. I would like to ask Dr. Prasad Narayan to join. Dr. Prasad Narayan.
Good evening. Yeah, thanks.
And can you stop share your screen?
Yeah, I'm trying to do that. Sorry.
Dr. Roshni, it was an excellent presentation. So I think we will just discuss some practical aspects of this, because we have just started using Phesgo, and what are the experiences and what are the issues which we are facing. So what are the main issues which you have faced when you switched over to Phesgo?
Sir, one is the patient initially actually feels that you're giving 15 ml of solution to me.
Right.
The patient has a fear of pain. But
right.
In my observation, it is patient actually doesn't end up with any pain, and there is no swelling also. So it has been quite manageable. And among the few patients that I've administered till now, one of them had ended up with grade 3 diarrhea, but that is already a known adverse event with pertuzumab. So apart from that, very truly speaking, I have not found a lot of difference between subcutaneous and IV formulation. And given the fact that these patients are going to receive injections for a year or so, chemo port, which is like an invasive procedure to put a chemo port, is probably something that can be avoided in the future.
Right. But presently, whatever patients I have had are the ones who were on the IV preparation where we are trying to shift them. It has been slightly difficult to even, I mean, convince the nursing team. So I will take this question which Rahul has put very. But Rahul, you are there online. So Dr. Rahul has asked.
Dr. Rahul can actually join if he is there.
So Dr. Rahul's question is, what happens to the vial half used if the patient develops a local or systemic reaction? Can we store it or use it again? Do you have an answer to that question?
Actually, I don't have that answer to that question. I'll have to see the medical insert. But as far as I know, this particular drug, the storage is different, but once it is broken, I think it can be used again like a multi-dose vial of 440 milligram trastuzumab. But I have to confirm this. I'm so sorry.
Right. So can the organizers make Rahul a panelist so that he can unmute and ask his question or discuss also, because
he is there. I think we can. I think he should be there.
No, he's there, but he's an attendee. Is
he even listening?
Anyway, Dr. Srinivas, what is your experience?
Yes, sir. Yes, sir. So support team make sure.
Rahul as to join the session, please.
Yes, sir. So support team, can you just make Rahul, sir, as a panelist?
So, Dr. Srinivas, what is your experience? What have been the issues which you have faced with FESGO, if you have given?
As Dr. Roshni told, it's for the first time for the patient to tell that 15 ml of injection, as she rightly pointed out. Probably that is the one thing which we need to counsel them, and nothing will happen. We can handle it, because they say, even because when we tell GCSF itself, they say, oh, that injection has to be injected. Then now telling them 15 ml of injection to subcutaneous, something it will be very new for them. I think we need to counsel them regarding the same.
Right. So I had the patient which I had a unique situation that she was on fulvestrant, denosumab, and this. So
yeah, all the three are subcut.
I had real stuff.
That's interesting.
So we'll take Dr. Harish. Dr. Harish, any experience and anything which you want to share of shifting?
Harish, you can unmute.
The IV to subcutaneous trastuzumab, pertuzumab.
Well, I myself am apprehensive about the subcutaneous formulation because just because it is new. Whatever patients whoever have received, they have not complained about pain or immediate reaction like redness or itching. So that is an encouraging sign. Yeah, probably after chemotherapy, I would agree. It's a very good option.
Sure.
Not only on quick line and we want to remove it. Very good option.
Sure. I think that's all I have to discuss on this. And thanks, Dr. Roshni, for a wonderful talk.
Let me just add, in the actually for patients for whom we have been thinking over to switch over from IV to subcutaneous, especially those who already have a chemo port, they don't prefer it.
Right.
Because they are of the opinion that we already have a chemo port.
Absolutely. This is the same thing which I am facing. And another thing which I don't know is the insurance actually. Insurance, whether it will approve a subcutaneous injection. And some patients, if they say, most of the patients which I have, both of them are on the patient assistance program. So it was easy convincing them to go for subQ. But if they have to pay and they are paying this much money, I don't know whether in Indian mindset they will accept this is the same thing which we had to face when Velcade came first. I don't know anybody in this panel, maybe CN Patil, I can see his name. I don't know whether he's online. So when Velcade was the innovator brand and it came, when we had to push it as an IV push, sometimes some patients have asked me why you're giving it so fast. Actually, it was much more expensive than what it is now. So some just like that, some patients don't want such a fast I mean an expensive drug to be given so fast. So some general comments, that's all.
And Dr. Prasad, I have a question for you. If the patient is on trastuzumab pertuzumab combination IV,
yeah,
now would you change or would you convince them to go for subcut?
Yeah, we have the 2 patients whom I have changed were on IV, and they were on the support program phase of pertuzumab, and they shifted actually.
Okay. But some insurance, as you said, they require an ward admission.
Right.
And that itself is another challenge actually.
Right.
Subcutaneous, why you need to admit? The insurance guy will ask you, if it is a subcutaneous preparation, why you are admitting it?
Right.
But actually the cost comes down, sir, because with this you don't have to pay for the trastuzumab. It's almost as similar as
pertuzumab. He will not understand all these things. He will
I
just
think we
say,
will ask Satish. I can see Satish there. Satish,
yeah.
comment on
Yeah.
that.
Yeah, I'm having one question actually to Roshni and Prasad sir. See, we know that trastuzumab will have a 3 week will give. Yeah, we know that we have some side effects which might get delayed 1 week, like 4 weeks. Beyond that, we are supposed to give a loading dose. Okay. This FESCO, like suppose is crossing more than like suppose 4 weeks, 5 weeks, 6 weeks, when we have to give the loading dose.
6 weeks is the cutoff.
Yeah, that's what.
As per the medical insert, it's a 6 weeks.
Yeah, that's what that's a one thing I wanted to know from you. The 6 weeks, that's what. Yeah, but other things are like, say, the one thing is hospital are not happy because of they won't get the money about the admission and all the things. That the problem is the company people, they may be happy of selling easily. That's all. They may be selling like in the pharmacy level, and they give administration at outside also. But problem is like the institution and the hospital the people may not be happy. That's all.
Next level
That's
is the
what.
patient will ask, why are you charging so much for a subcutaneous preparation?
Right.
Yes, yes.
Yeah. Fine. Thank you. Thanks, Dr. Roshni.
Thank you.
Thank you
Dr.
so
Sridhar Gupta and Dr. Prasad Naran for that excellent presentation. Now we'll move on to the next topic, Pfizer sponsored session on real world data of palbociclib in metastatic HR positive, HER2 negative breast cancer. I welcome Dr. Harish, who is a consultant medical oncologist at Site Care Hospital, Bangalore. Dr. Harish, over to you. Harish, are you there?
Yeah, I'm here. Share my screen. You cannot share screen when the other part sharing. Last person has to sharing the screen.
Are you able to share the screen, Harish?
I'm getting you cannot start the screen share while the other participant is sharing.
So do you want?
What happened, Harish?
Yeah, now I'm able.
Yeah.
I hope my screen is visible.
Yes, sir.
Yeah, it's visible. It's visible.
Yeah. So, good evening, everyone. Thanks, Dr. Srinivas, for arranging this wonderful meeting. As every year, ASCO meeting is one where we get new blockbusters.
So you need to make it full screen.
Okay. Okay. So
yes.
So this year, ASCO blockbuster drug, you can say, the trastuzumab deruxtecan. Many papers concentrated on HER2 positive or HER2 even HER2 square breast and gastric carcinomas. So this year, blockbuster drug is trastuzumab deruxtecan. My next few slides, I'll be discussing about the blockbuster drug which was presented in last few ASCOs. So that is about palbociclib, checkpoint inhibitor, which was used in hormone positive HER2 breast cancers. So you know, letrozole and tamoxifen have been there around for last 30 years probably, and there was, except for fulvestrant, there was not many other advances in recently in hormone positive breast cancers. And this cyclips, the CDK4 inhibitors are the newest entry, and this is, I would say, one of the new class of agents which have made a real difference in metastatic hormone negative breast carcinomas. Progression-free survival as well as the overall survival is almost doubled as compared to what you get with single agent fulvestrant or letrozole. So this time in ASCO, mainly it has been the follow studies and the population-based studies. So in my next few slides, I'll what we have found in real-world data in palbociclib. So, as you are all aware, it's a cyclin D1 and CD4 signaling pathway leads to proliferation and proliferation signaling, and it is where palbociclib acts transcription from G1 to the cell cycle. There are various inhibitors and suppressors and promoters which are in play. PI3K pathway, MAP kinase pathways, hormone receptors, NF-κB pathways, cyclin D, and it negatively activates Rb and enhances phosphorylation that leads to synthesis. So, it is in this pathway that CDK4 cyclin D inhibitors downstream pathway from ER activation. So we all know that palbociclib is a first-in-class CDK4/6 inhibitor. Say it's one of the path breaker innovation regarding the CDK4 inhibitor. It's an orally active agent, and it inhibits the cell proliferation and DNA synthesis from G1 to S of the cell cycle. And this is the recent updated indication of palbociclib for women. Is in combination with the aromatase inhibitor in first line as well as in second line, third line treatments, and in combination with fulvestrant who have received prior endocrine therapy. Pre and perimenopausal women, we usually combine Relapse RH agonist or antagonist when post-menopause and fulvestrant. And for men, indicated with the aromatase inhibitor as endocrine therapy. Again, we have to use LHRH agonist, and also it is indicated along with the fulvestrant received prior aromatase inhibitor. This is the current updated indication for palbociclib. So, as I said, one of the first molecule checkpoint inhibitor to be released in the world. So there is a very large data available in real world experience in 2015. That was 7 years of checkpoint inhibition, and we have one of the longest data for checkpoint inhibition as compared to other CDK4 inhibitors. Now, I'll just take you through a few of the larger retrospective, mainly from patients from the United States, where we have recommended medical. Platinum is a real-world retrospective analysis of breast cancer as compared to lateral. So there is data available from more than 280 sites of care and almost 2.2 billion after 2015 in 2019. There is a propensity match scoring to match those patients who receive letrozole alone as compared to palbociclib. Further, we could not take in more patients were started on the checkpoint inhibitors. So after propensity matching, we have data for 460 patients palbociclib compared to letrozole alone. This is a real world data. Unadjusted analysis, median progression free was around 11.9 months as compared to 19.7 months. I would say almost doubling of the progression free survival here. And median OS was 40 months in those who had received palbociclib letrozole alone as compared to those it had not reached those patients who had used palbociclib. So even we can say at the almost like 4 years, there's almost 15% versus 30%, doubling of the survival, progression-free survival, the use of the use of palbociclib. Again, the benefit was seen in even after propensity score match. Again, similar numbers, 11.9 versus 20.2, the progression-free survival, and the survival, overall survival is 43 months versus not. Now, this benefit of palbociclib was seen across all age group, regardless of the metastatic sites or visceral or bony sites, but there were multiple metastases, few oligometastases, so it was seen in almost all the subgroups. So the conclusion of this retrospective evaluation was that even after the propensity matching, almost 50% additional benefit by adding palbociclib compared to letrozole. And another retrospective chart this time from both USA and Europe population. The 24 months progression free survival at 2 years after start was around 64%, 62% the continents, USA and almost 93%, 92 to 96% of patients benefited the addition of palbociclib. And the good thing about is the progression-free survival rate. Even after 2 years, many patients had progressed, and which was not seen with any of the. And the overall survival rate, both USA and European, 5%, 12 months, and 12 months survival in Europe was 96%. Almost all the patients who were started had a clinical benefit. So this is the real world data. We all know that the drugs, whatever we see in the clinical trials, will not be translated into real world data. What we have seen here is that even the real world data is as impressive as was seen in the clinical trials. Another Medline US data, again, data for patient reported outcomes, quality of life questionnaire, and only 2% had grade 4 neutropenia, and though there were a lot of days of neutropenia, of the patients reported a decrease in quality of life, and in fact the patient had reported better quality of life throughout the follow-up period in those who had received palbociclib. There was a low level of fatigue, and which remained static period of time, and it was there regardless of but the treatment satisfaction score was seen here. They had active questionnaires of expectations. Satisfaction was therapy. Thus, more in those patients who had received palbociclib as compared to single agent letrozole. Coming closer home, there have been many studies, real world studies have been This is from the Delhi group from RGCA and BLK hospitals 188. Again, similar progression-free survival as we have seen in the Western data. Progression-free survival of around 20 months, and 10% had the grade 3 or 4 adverse events, and no patient had febrile neutropenia. So, population. This is the data which we have seen in countries also similar. Even from Bangalore, there is multi-center perspective evaluation, and almost after 38 months, progression survival was not reached. De novo patients and relapsed at the almost, and as a second line, it is similar one again. 8% patients had dose reduction, and was efficacy is similar in Indian patients as we have seen with melanoma type. And another Cancer Institute, Chennai, similar progression is 18 and most and the majority of these patients had very advanced disease. 70 to 80% of patients had relapsed medicine, and almost 19% patients got a complete response. 24% of the patients required dose reduction. We can see in some of the, and there was an unusual number of patients brain metastasis who achieved a complete metabolic response with letrozole and palbociclib. And so, if we say, has palbociclib changed the treatment paradigm? It is an emphatic yes. Never before we had seen such a improvement in the progression-free survival in hormone positive. There were newer advances in HER2 positive breast cancers, mainly trastuzumab, pertuzumab, emtricitabine, now deruxtecan, tucatinib. There are so many new molecules in HER2 space. In hormone positive or HER2 negative, the change and only change that we have observed is point inhibitor and palbociclib first. There's data for palbociclib. Okay. With this, I would like to conclude. Thank you.
Thank you, Dr. Harish, for that excellent presentation. Our Indian experiences are actually very important because we try to extrapolate all the time Western data, but we have our own Indian data. And when we say that the Indian data is closer to the trial data, it always gives a good confidence in our clinic to practice. So that's very important. Now, I thank you for that excellent presentation. Now I welcome Dr. C.N. Patil for the next session. This is a Novartis sponsored session, picking the right strategy for patients with HR positive or negative PIK3CA mutation. Dr. C.N. Patil, over to you.
Thank you, Dr. Srinivas. Am I audible?
Yes, sir.
Yes, sir. You're audible.
Yeah. At the outset, I would like to thank the organizers for giving me this opportunity. The topic given to me is picking the right strategy in hormone positive, HER2 negative, PIK3CA mutation patients. So PIK3CA is the most commonly mutated gene in HR positive and HER2 negative advanced breast cancer patients. Nearly 40% of patients with HR positive, HER2 negative advanced breast cancer.
Hello. Sir, your screen is not in full mode screen, and you have to do enable editing from the top header.
Patil sir.
Yes.
Just make it full slide, sir. and make it that enable editing. Above you can see that enable editing.
So you can reshare your screen by stopping and then again reshare the slides.
I shared the screen and made it full screen only.
Yes.
Now?
I think so. Now it's.
Now?
So just do that enable editing from the top.
One which you are seeing above, sir, enable editing. You can see that on the center top. Just click that enable editing.
Yeah.
Yeah. Correct. Now we can.
Should I share the screen now?
Yes, sir. Please share.
Escape. Sir. Correct. Now you can do a full screen. Correct. Just do a full screen. Correct.
Yeah.
Yes, sir. Now it's there.
Yeah. Sorry for that glitch. PIK3CA is the most commonly mutated gene in HR positive, HER2 negative advanced breast cancer patients. Nearly 40% of patients with HR positive, HER2 negative advanced breast cancer have a PIK3CA mutation. And all of us know that patients with PIK3CA mutation face a worse prognosis. So why patients with PIK3CA mutation need different approach is the question. So it has been shown from genomic analysis of 649 metastatic breast cancer patients and meta-analysis of 1929 cases of patients with breast cancer that presence of PIK3CA mutation was a negative prognostic factor and associated with poor response to therapy and a worse prognosis, overall prognosis in breast cancer patients. So PIK3CA mutation can be a biomarker of response to treatment and predictor of prognosis of in breast cancer. So knowing your patient's PIK3CA mutation status may help in developing upfront treatment strategies. And we all know that PIK3CA mutation helps in cell proliferation and tumorigenesis and leads to poor prognosis and endocrine therapy resistance. So knowing our patient's PIK3CA mutation status may inform upfront treatment strategies and response to treatment. So alpelisib or Pluvicto specifically addresses the PIK3CA mutation. It may lead to PIK3CA mutation can lead to hyperactivation of PI3K, a key upstream component of PI3K pathway. And Pluvicto inhibits alpha isoform of PI3K 50 times more potently than other PI3K isoforms. And it works synergistically with fulvestrant. And targeting PI3K mutation may overcome resistance to endocrine-based therapies used in HR positive, HER2 negative advanced breast cancer patients. What are the preferences now? So when to test, whether to test upfront or on disease progression, or it should be tested on archival tissue or repeat biopsy at disease progression, whether RT-PCR or NGS is used, and what is the concordance of tissue-based and plasma-based PIK3CA mutations. All this we shall answer in the next 10 minutes. So why test for PI3K mutation? It's a critical component of HR positive, HER2 negative advanced breast cancer management. And patients with PI3K mutation face a worse prognosis and they are eligible for biomarker-driven therapy with alpelisib. And we have to test for PI3K mutation when a patient presents with metastasis from breast cancer and they are generally stable. And we also do the testing when the patient has endocrine therapy resistance. Alpelisib is a critical component to the upfront treatment plan of HR positive, HER2 negative women who test positive for the PI3K mutation. And alpelisib plus fulvestrant is a category 1 option in the NCCN clinical guidelines for the management of breast cancer patients. If the patient has recurrent stage 4 metastatic disease, tumor is HR positive and HER2 negative, and if we are considering with therapy with alpelisib, we can either do from the tissue or liquid biopsy. And if it's positive, then alpelisib plus fulvestrant is an approved category 1 recommended treatment. And this is the landmark trial. All of us know about this trial. SOLAR-1 is the first phase 3 trial leading to an approval specifically for advanced breast cancer patients with a PI3K-CA mutation. And this was a randomized double-blind placebo-controlled multicenter phase 3 trial. And the inclusion criteria were postmenopausal women and men and more than or equal to 18 years old, HR positive and HER2 negative advanced breast cancer patients. They had recurrence or progression of breast cancer during or after aromatase inhibitor therapy, PS0 or 1, and PI3K mutation was identified. And they were randomized 1:1 fashion to alpelisib plus fulvestrant versus placebo plus fulvestrant. And the primary endpoint was PFS. And as we can see in this slide, the median PFS doubled in patients who were treated with alpelisib and fulvestrant. It was 11 months versus 5.7 months. So nearly 2 times benefit in patients treated with Pluvicto and fulvestrant. So it's a category 1 option in patients with advanced breast cancer who have PI3KCA mutation. And this was the PFS result across the subgroups. As we can see in this, that across the subgroups, the benefit was shown. And if you can see in this slide, the prior CDK4 inhibitor treatment was given only for 20 patients. Whereas in clinical practice, we end up using Pluvicto plus fulvestrant after failure of palbociclib or ribociclib plus letrozole in majority of the scenarios. Whereas in this trial, majority of the patients were not exposed to CDK4/6 inhibitor. And more than double the response rate in all the subgroups were seen with Pluvicto plus fulvestrant. And tumor shrinkage was observed in 3 out of 4 patients with PI3KCA mutation and had a measurable disease at the baseline. And what is the dosing and administration of alpelisib? The recommended dose is 300 mg, 150 mg, 2 tablets taken orally once daily with food. And the recommended dose of fulvestrant, all of us know, and it is given in combination with fulvestrant. And the dose modification is advised if the patient has severe diarrhea, rash, or hyperglycemia. Next dose reduction is to 250 mg and subsequent dose reduction is to 200 mg. If the requirement is less than 200 mg, it's not advisable. And the ideal considerations before initiating alpelisib. So what are the side effects we should expect and how to manage them to improve the patient's compliance and quality of life? And hyperglycemia is the very significant and the most common side effect which we see when we use alpelisib. It invariably occurs in all the patients, and we have used in 5 patients, and all of them invariably had hyperglycemia, irrespective whether they had diabetes or not. And how to reduce and manage, and how to reduce the rash, and what is the role of prophylactic antihistamine. So as you can see in this slide, the predominant and the major side effects were fatigue, rashes, and hyperglycemia. So rash and hyperglycemia constitute the most common side effect when we use alpelisib. And it is an on-target effect of PI3K inhibition. See, PI3K drives the insulin signaling through PI3K drives the glucose uptake into the cell. So when we inhibit PI3K pathway, the glucose is not driven into the cell and we get hyperglycemia. And how to manage hyperglycemia? Honestly, if you ask me, I'm not practicing it. So we do take help of endocrinologist, and it's quite cumbersome, but it's better to hand over to endocrinologist upfront before we start alpelisib. Better to inform them that we are starting alpelisib plus fulvestrant and sugars are going to go up. And all our patients are managed by endocrinologist. And we hardly get into the management of sugars, but it's a very important component to ensure the compliance of the patient. And the only laboratory monitoring needed for patients on alpelisib is for fasting plasma glucose and HbA1c. And it should be strictly monitored, and the sugar levels should be monitored and addressed accordingly. The recommendation is not to use insulin, but invariably we have ended up insulin in all our patients, and we leave it to the endocrinologist to manage the diabetes part of it. And prophylactic management of rash is what we can do, and it decreases the incidence by a significant amount. And the prophylactic use of antihistamine has shown significant reduction in the grade 3 or grade 4 rash in the patients received prophylactic antihistamine. So we have to consider using prophylactic measures, including antihistamines, at initiation of and during alpelisib tablets prior to the onset of rash. So alpelisib assessed quality of life impact on URTC and BPI scales showed that the quality of life was well preserved in patients who were taking alpelisib and fulvestrant. It was maintained on alpelisib treatment. But honestly, if you ask me, in the practical practical scenario, patients, maybe because of the disease progression, or they are heavily pretreated, or due to the rashes or diarrhea or hyperglycemia, the fatigue is significant. The fatigue what we see in patients on alpelisib and fulvestrant is definitely significant, but studies have shown the other way around, that it was it favored alpelisib physical and emotional functional assessment and showed a positive impact on symptom management. And so the most important take-home message I would say is it's a very important armament important drug for the management of patients with PI3KCA mutation in HR positive, HER2 negative breast cancer patients. The dosing is 300 mg once a day, And we have to be aware of the hyperglycemia, which occurs invariably in all the patients. And we can prevent the rashes by prophylactically using antihistamines. So to conclude, PI3K-CM mutations are present in nearly 40% of HR positive, HER2 negative advanced breast cancer patients and indicate a poor prognosis. And alpelisib tablets specifically target PI3K-CM mutation. And it nearly doubled the PFS as we saw in the SOLAR-1 trial. PFS was 11 months versus 5.7 months. And it more than doubled the response rate. And safety information in patient-related outcomes we discussed already. The adverse events with Pluvicto were manageable and reversible. And in SOLAR-1, there was no statistical difference in deterioration of global health status or quality of life between the arms. And physical, emotional, cognitive, and role functioning scores were similar to those observed in the placebo group. And clinical decisions must consider efficacy and tolerability taken with clinical efficacy. And alpelisib definitely showed a meaningful PFS when it was added to fulvestrant. And this is what I have to say about alpelisib and fulvestrant. In fact, I wanted to share one patient who had a very remarkable response, who had taken palbociclib plus fulvestrant for 4 years and then progressed, and she was PI3K-CA positive. And we used alpelisib and fulvestrant, and we saw a remarkable response in PET scan. Out of 5 patients, this was the patient who had remarkable response. And touch wood, she is tolerating 300 mg, and hyperglycemias are managed with insulin, and she is on prophylactic antihistamines. Thank you.
Thank you, Patil sir. That was a wonderful presentation, and what you are told is something, it's very important.
So, 90 days.
Am I audible?
Yes.
So there are now a lot of biomarkers. As you said, nearly to the tune of 40% is something remarkable percentage of patients who carries this PIK3CA mutation. I think, as you said, one case what you shared is something very impressive. Post palbociclib progression, and she's doing so good with alpelisib. That's something very interesting. I think post palbociclib or post CDK4/6 in progression, now we have many other drugs. I attended an ASCO 2022 this year. Lot of presentations on alpelisib upfront post CDK4/6 progression, and is a great drug, and I think one of the very good biomarker driven drug. I think
maybe we still are in the learning curve. Once we get into the groove of using it, then we'll be managing the side effects.
Exactly. So more and more number of patients piping in, and we learn how to manage those side effects, and it's an important issue there. Thanks for that wonderful and lucid presentation, sir. Now I move on to the next topic. Getting real with ribociclib, bridging the RCT and RWE universe with evidence across 8,000 patients. And I welcome Dr. Satish, who is a senior consultant medical oncologist in HCG Bangalore. Dr. Satish, are you there?
Yes, I'm there. Yeah.
Over to you, Satish.
Okay. Thanks, Dr. Srinivas, giving me opportunity to talk on the experience of the ribociclib. That is on real evidence what is published in this ASCO. Coming to we know that there is a 3 CDK inhibitors there. Like we'll see that everybody used this is the CDK inhibitor. There we know that randomized trials, we may be part of the trial, some we definitely don't have opportunity. Right? There is the data there real world evidence that gives a boosting, give the use of these drugs. Like we have to see how we have to dissect into data in various subgroups, because which is not given the evidence in the RCTs. This is one data is I'm going to present on having a huge number, that is almost 8,000 patients. My slides are moving.
Sir.
Yeah. Coming to the when you're considering options in advanced breast cancer, when you're going for approaching the medical oncologist, what is the best outcome when you're assessing that? Previously, we used to tell when the statistical significance and getting FDA approval, the people used to have PFS. because overall surveillance, the evidence is the most important. We ask anyone, even ask the oncologist, whether it's a patient, everyone, oral surveillance is the most important gold standard endpoint in any clinical trial that measures the efficacy of any oncological trial. Even years of day, that is gives one of the important endpoints. Like that is one of the preferred endpoint. But what are the other endpoints, like when you're going for biosimilar oral response rate and PFS is other endpoint markers will be taken in the clinical study. Coming to the this marker, we are all the three CDK inhibitors are there. This is the only ribocyclic CDK inhibitor shown the statistical significant overall survival benefiting across all phase 3 data are there. You can see here that the three phase 3 trial like RCT, that Monalisa 2, Monalisa 3, and Monalisa 7, showing that like first line and one of this Monalisa 3, it includes both first line and second line with various endocrine partner, showing all the subgroup. This is one of the landmark trial showing the overall survival in all the phase 3 data. Because if we come to the other marker, like CDK inhibitor, you can see the full Western showing the second line and first line, like one of the Monarch 2 data is there supporting for this. But we don't have any other data to publish for the overall sector, that we have to have a mature data to have a longer follow-up and should have that. Coming to the overall median survival rate, having almost 5 years with the first line, if we coming across the various endocrine partner or irrespective of the menopausal status, if you see that ribociclib is showing that it is one of the endocrine marker. It's showing that is increasing the median survival is more than almost nearing to 1 year. You can see is that the data is there is Monalisa 2 is showing that almost is the highest, like is almost 63.9 months as a plus to almost 12.5 months having a benefit in this study. And if we are coming to that Monalisa 3, almost is having with the full Western, you can have 67.7 months. When if we are coming to the Monalisa 7, it is a perimenopausal or premenopausal woman, can have there also is almost like nearing 11 months of benefit. You can see that irrespective endocrine partner in the first line is showing almost nearing the overall survival rate of 1 year. You can see that we have this RCTs are there in a first line, all showing that boosting that we are encouraging to have any patient comes that okay, this is overall survival rate is we have data with ribociclib. Can you have that? Because you cannot have a same RCT, cannot be replicated in a clinical practice, various problems, actually practical challenges. You cannot have a same kind of patients you can have because various comorbidity, performance status, various clinical scenarios can be there. Here I'm the data that the real world evidence we are having that we are having almost more than nearing to 8,000 patients, like 5,800 patients. You can see that there are two large data is there from one of the complement study, and next other one is a Ribana study. You can see this is the real world evidence from these two complement studies having almost of 3,200 odd patient. Ribana study is having almost is from the German subgroup of the German population having up like almost 2,500 odd patient. Let us go through the data in detail. You can see that if you do data, like if you're almost having nearing a 5,800 patient, is having the largest population to have this kind of giving a boosting to have the evidence is there other than the RCTs. Coming to the complement study, here having almost near into 3,000 patients. You can have here is a men and women with a HR positive patient. Here no prior endocrine therapies and none of them chemotherapy are very less number. Can have that CNS metastasis was permitted, that those are stable for more than 4 weeks. That is one of the, because they are like if you are going for RCT previously, they are having exclusion criteria. Can see that this here Ribana study, you can see that first line study that they're having into 3 subgroup. One is a combination hormone therapy with the ribociclib, endocrine monotherapy, and chemotherapy. That's what the practice used to have. Some of them institution, we don't have this. We are having this kind of real evidence, but many people they try to practice because not access to these kind of drugs. You can see this one of the largest data from that is a complement study. You can see here that we are having a diverse subgroup populations. We may not have in a RCT. So like that's what one of the lacking. This kind of things we can give a very boosting us to give the okay, this drug is helping us. Let us see how the data is going to have a in effect. Actually, you can see here almost like 51 number of patients having the CNS metastasis. And here they are having a prior chemotherapy, almost nearing 195 patients, and visceral metastasis. You can see the maximum number of almost like a visceral metastasis. I can see 1,900, almost nearing 2,000 patient. And performance status, you can see that is a 2 because many trials there like performance status are 0 or 1. We cannot have this. At least where I'm population like various subgroups can in this study. Coming to the safety of this molecule, what was observed, it is almost like predictable, manageable, and similar to the what phase 3 RCTs, and it is almost like they are reduced and prolonged. Once you have the initial period, it is what you can see here. Like initial period is the maximum. We will try to have the toxicity, especially neutropenia, the alteration of liver function test. Sometimes, very rarely, that ECG you have to monitor that. Once you have that, when the duration of exposure is there, the toxicity will come down. They're all become patient friendly. You can by 3-4 months, you can the dose is be the adjust to the patient is that it is the final dose and patient is adjusted for that. You can see here, look at this table. You can see that adverse event almost 75%, SA is 18%, fatal event less than 2%, leading to discontinuation, and dose adjustment was seen in a 64%. Almost 2/3 of patients was seen because you can see that various diverse subgroup, parameters, visual metastasis, because you and performance status also 2. These kind of things was included in this study. Coming to the efficacy, what we used to do previously, that landmark and the endpoint used to be PFS. That is a PFS. You can see is almost median PFS is almost a time to treatment progression was 27.1 month in this. You can see percentage of event-free survival rate in this 12 months is almost 75% of people. So 2 years 54%, and 3 years almost like nearing to 40% of people still they event-free with this drug. It is very encouraging to have this kind of data with the real world evidence. Coming to the response rate, you can see overall response with the total population is almost like you can see that near into 30%. You can see almost like the clinical benefit rate like you can see that like you can see almost 71% of the patient. If you are coming to those that have measurable disease, because this include only bone disease like without measurable disease, here like almost 69% of people they got a clinical benefit rate. This is a very excellent drug in that showing that promising that this kind of response in this kind of thing. Coming to going to the one of the various diverse subgroups, what we had that kind of a population, you can see that CDK inhibitor with CNS metastasis do have any data in phase 3 like RCTs? No. You can see here Mona Lisa ribociclib related data is excluded in the Mona Lisa 3. Here 8 patients were there with the stable brain mets was there. Mona Lisa 7, no patients. Coming to the palbociclib related study, one of the Paloma study, 2 patients were there. Paloma 3, the 5 patients were there. Like and abemaciclib, you can see that we heard like that theoretically it is having highest better CNS penetration, but phase 3 data I don't included in this like the exclusion criteria. But you maybe have a data like a phase 2 data with abemaciclib with that, but they had like a 3 patients had like they have confirmed that 5% of patients they confirmed that they are responding to the brain mets actually. But you can, if you have a data that are largest number that is can complement phase 3 like that's the real world evidence is showing that 51 patient having a CNS metastasis. Let us see that how is the response. You can see that overall response rate and those are having CNS metastasis. You can see that like data is almost, you can see that the thick blue graph is showing that general population, overall population 27.7 months, 27.1 months. You can see that other one is showing the almost like near equivalent to the CNS, those are having CNS metastasis. Coming to the those who received a prior chemotherapy, and the overall population, you see that the difference, like you can have a difference of this difference between the overall population to prior chemotherapy. You can see that still they're having 18.4 months of PFS benefit. Performance status is having the PFS benefit is almost nearing 20 months benefit. And you can see visceral plus prior chemotherapy, the benefit is almost nearing to the 13.7 months. And those are visceral mets with performance status is low, that is a PFS of 2, showing that almost benefit of 10.8 months. You can see that various subgroup benefit, like this kind of even worst type of subgroup people, they try to have this kind of the benefit is there, that even CNS metastasis also is increasing. Coming to that quality of data, you can see that looking at the fact B, emotional and functional well-being scores were done, showing that almost there no much difference actually compared to the baseline and the end of the treatment with this molecule, suggesting that this drug is not going to have any decremental of quality of life, showing that maintaining the quality of life with this, we can use that. The maintenance quality life is also important, is one of the factor when you're treating addressing the advanced breast cancer. This is the second study, the real world evidence, that is Ribana study, that is a clinical evidence from the German group, is ongoing prospective non-interventional study. You can see here there are 3 subgroup of people are there, is having almost nearing a 2,500 an hour patient in this. You can see here one of the subgroup is a ribociclib with a endocrine partner. It can be aromatase inhibitor or in a fulvestrant, endocrine therapy, monotherapy, or chemotherapy. You can see the 3 components was there. Median age group is slightly different. And the menopausal status and echo performance status, you can see that there is slight difference there. You can see that visceral metastasis, you can see liver, CNS metastasis also, you can see they're having some difference in classification. Bony metastasis, only you can see here this a less number of patients. Here endocrine monotherapy is almost 50% of patients. You can see here the PFS benefit with the endocrine, the adding ribociclib definitely showing that PFS benefit is at 31.7 months. With endocrine therapy alone, 25.7 months. Chemotherapy, you can see that chemotherapy is below the category even to the endocrine therapy. That's why endocrine therapy with ribociclib is very impressive with this data. Coming to the safety, you can see here the QTC prolongation and alteration of liver enzymes and blood bilirubin, all those things. You can see that in the ribociclib group is a grade 3 is very less than 2. It is a very less, is a not a very significant, very less number of patients can have that if we go compared to the other subgroup, actually chemotherapy arm and endocrine therapy. The most common in the adverse event, what was noted is a neutropenia and nausea and fatigue. What was this? It has shown that leukopenia. This is the most common thing. The maximum is observed in the other study was the first a couple of months, that when over a period of time it is going to decrease. That route is almost we are seeing similar to what we are seeing in the other RCTs, Mona Lisa studies. Coming to the comparison, the RCTs versus a real world evidence, you can see here the complement study, the median PFS is a 26.7 month. Ribana study showing the 37.1 month. You can see these other Mona Lisa 2, 7, and 3. You can see is almost it's a very consistently showing almost similar to the RCTs. You can see that dose reduction also, here is a 87%, 88% of the patient, 68% of the patient. Here in this Ribana study was a 32.3%. Discontinuation rates, it is a 13% in the complement study. Here is not reported. We're supposed to have that follow-up, and also the rages perspective still ongoing actually. And if the most common side effect, grade 3, grade 4, toxicity is more than 5% of patient. What was noted is it is a neutropenia, leukopenia, and alter LFT, and this all the thing is almost similar to the RCTs. You can see the guidelines. The preferred, which is a preferred endocrine therapy, that is a hormone endocrine therapy, that is the most important, is aromatase inhibitor with the CDK inhibitor. Any one of the partner, Abima, Valbo, ribociclib is a category 1. Otherwise, you can have other alternate options. A fulvestrant with plus combination with the aromatase inhibitor. There's other alternative thing. Next other one is a fulvestrant with CDK inhibitor, where I'm the phase 1 the category where I'm category 1 is a various other molecule, the ribociclib, almo, and abemaciclib. This is a category first line therapy. It is there, but like this among this the option, the one of the ribociclib endocrine therapy, it is showing this one of the data showing the consistently oral surrogate benefit in the first line setting. It is very encouraging. This is only CDK inhibitor showing that is having longest oral surrogate so far, so published till now. Coming to the going for the ESMO, that magnitude of clinical benefit score, like if you show that the clinical benefit rate, if coming to the RCTs, you can see that all the like 3 molecule, you can see that almost oral surrogate gain is there, that is more than 1 year. PFS benefit also you can see that is more than near to the 10 months, and quality of life is maintained in this 3 2 Monalisa 2 and 3. Monalisa 7 is shown the quality of life is shown as improvement. The score you can see that 4, like it's showing that is a definitely showing the improvement in the the quality is a positive impact on the the score on the it is definitely making the confidence of using this molecule in the first line setting. And the Monalisa 7 it is showing that the score is that the almost a 5 point, and is a quality of life is improvement is a very encouraging to use this. And this next one is it these 3DK inhibitors that are no same or different? Yeah, definitely they're not same. You should know that this is a biology, the basic biochemistry of this molecule, actually how they work. Actually, you can see that ribociclib number of targets where it is definitely is like the ribociclib, palbociclib, and abemaciclib, showing the different toxicity profile, and also that targets what we say that like a selectivity based on the target where it is going to target. The CDK4 is targeted like is more commonly with the CDK6 with this ribociclib and abema, but the palbociclib both are affected equivalently. That's why you try to have a more hematological toxicity compared to other molecule, and the benefit is more with this actually. That's why so far we are having that. And you can see that the highest selectivity of the CDK4, what we see with the ribociclib, and also even the abemaciclib. So far you can see here preferential inhibition of that IC50. You can see with the ribociclib 8 times, if you use that you can get this one. Abemaciclib 6 times. Palbociclib you can see that almost equal 1 time is going to have this one, because you can have that free drug concentration should have a 22%, means that like even less than a small quantity can try to have the target at this CD4 count, and they'll have a less toxicity profile. That's what is going to selectively is targeting CD4 expression compared to the CD6. That's why I try to have this so far benefit. This may be the expression, we don't know that all 3 drugs are not the same thing. All drugs are working, but they're having differential magnitude of benefit. Each molecule have different toxicity profile they're having. We should make the personalized, and what we have that. Coming to my last slide of the talk is like outcome from the randomized the RCTs can be replicated in the real world evidence. What we are having a largest the data from these 2 studies, like the Ribona and the complement study, almost having 5,600 patients. Guidelines recommend early use of the CDK inhibitor in a patient with HR positive, HER2 negative, advanced breast cancer, among which ribociclib is the only CDK inhibitor demonstrated the longest median oral surrogate of almost 63.9 months in as per Monalisa 2 study. Significant improvement in the oral surrogate in across all the lines, like that is the endocrine part, irrespective of the endocrine partner. It can be aromatase inhibitor, it can be in fulvestrant, it can be irrespective of the menopausal state. It can be the data is there for premenopausal women, and also is achieving the good ESMO that magnitude of clinical benefit score of 4 to 5, that is across all the 3 RCTs, and almost like you can have a similar efficacy rate and safety profile what was demonstrated in this real world class evidence, actually what was having from 5,800 patients. And also this where that is that ribociclib demonstrated a consistent efficacy in all the subgroup, even including CNS. Like that was the important thing. We don't have data for in all the RCTs. At least we are having the real world evidence showing the data towards a person is having CNS metastasis try to have a benefit, and also visual metastasis. those are having chemotherapy followed by endocrine therapy, you are having data towards this, and also that ECOG performance status of 2 and more, we're having data with this with the ribosectib. It's boosting us to go with this kind of take-home message. And one more thing is most important: all three CDK4 inhibitors are not like same; they are different based on the how selectively is work target on the CDK4, and off target inhibition of the that is a CDK6, and toxicity profile is going to have that pre-drug concentration and potential benefit. What are the differences shown in the various studies, the efficacy and safety? That's why they're all not same. There are difference, but all the drugs, they are working in a different class of group, and the magnitude of benefit may be vary. You should utilize and you should make it. So far, our ribosectib has shown very great tested the survival benefit evidence in all three data what I presented. And even real world evidence is giving in a huge number, that is a 5,800 patient is a great number to have almost similar data towards the RCT. I'll stop here. Thank you. Any questions? I'm happy to take.
Thank you, Dr. Satish. That was an excellent presentation on the real world data as well. Due to the interest of time, we'll just quickly move on to the next session. I welcome Dr. Vishwajit K. Pai, consultant medical oncologist, Mysore, to talk on p-value to patient centricity in breast cancer. This is a Dr. Reddy's sponsored session. Dr. Vishwajit, over to you.
Yes, sir. Good evening, everyone. I'll be talking today on a topic that is going to be of great relevance to us shortly. It's titled From P-value to Patient Centricity. When we look at all the trials, we are very much worried about p-value, but how much of this p-value actually makes a big difference when it comes to patient or clinical practice? I'm going to be
Sure, can you just make a full screen of it?
Yes, sir. Yes, sir. Yes, sir. So in other words, I'm presenting the real world evidence on CDK4 inhibitor, especially palbociclib. As we know, Dr. Reddy's is coming up with a version of its own shortly, and many other companies are going to come up soon. So we need to know more about palbociclib and how it has affected our practice over the past couple of years. So these will be I'll be covering these broad topics. So what is actually the difference between a randomized control trial and how do we interpret that in a real world evidence? All our randomized control trial have a very highly select patient population. You know, they have a very strict inclusion and exclusion criteria, and most of the time, the most ideal patients, the most fit patients are selected for the trials. And when we look at the placebo or the comparator group, when we compare that to our patients in our real practice, they might not be exactly comparable. And many times interventions, say there is some adverse event and how the way forward for these adverse events is also again strictly standardized by the trial design. But in real world situation, we do not get such extremely fit patients. We have heavily pre-treated patients coming to our practice. Not all patients will be in perfect general condition, and we have to tailor the interventions as per our need. Hence, many times what we see in a randomized control trial might not be applicable completely in our practice. So the largest data on the use of palbociclib in real world comes from this study group called the Flatiron study, which included almost which looked through 2.2 million active patients across 800 centers. And in this group, they actually had a lot of patients who were more than performance status 1, and patients with brain metastasis were included. A lot of patients had previous chemotherapy, and 60% had some kind of chemotherapy earlier, multiple lines of therapy, multiple lines of endocrine therapy earlier, and a higher number of patients were there with multiple sites of metastasis and more than one site of metastasis, and more percentage of patients with visceral disease. So there's this concept of propensity score matching that we need to do when we are looking at retrospective data for analyzing real world evidence. But however, when it comes to palbociclib, you can clearly see that there's not much difference in spite of the correction with the PSM scoring. There is almost doubling of the progression-free survival in patients who have received palbociclib with letrozole. And we can clearly see that the two curves are separating right from the beginning, which proves that palbo-letro combination is much superior than letrozole alone. The same holds good for the overall survival as well. Again, in fact, the overall survival was not reached in the combination group, whereas it was 40 months in the letrozole alone arm. The forest plot, exactly like how it is in the Palomar trial, across all subgroups, we can see the additional benefit of addition of palbociclib to letrozole. So in conclusion, the combination definitely works much better than letrozole alone. The clinical efficacy that was seen in CDK4 inhibitors was also seen in a real world setting, and median overall survival was not yet reached in this study group. There are others. This was from the US. There's a second consortium called as the IRIS, which looked across USA, Canada, Argentina, and also the European countries. And this again mirrors the similar data. We see a lot of patients, the responses continues to be there even till 24 months across, and it's not just in US. You can see across different ethnicity as well, the results are obtained. A lot of patients do achieve partial responses more than complete responses, and overall response rate is about 74 to 80%. So in short, I'll go through papers from India. The first one, this is from Rajiv Gandhi Cancer Institute, New Delhi. This is the largest retrospective data of palbociclib in Indian patients. They included 188 patients who received palbociclib with letrozole. And if we can see, the median PFS when used in the first line with letrozole was 20 months, and when used along with fulvestrant in the second line was about 12 months, which is accepted. We can't expect a higher PFS in a second line setting. The same as well, the overall response rates drops down significantly when used in a second line. This is the real world evidence difference that we see. Because a lot of patients would have received some kind of hormonal therapy earlier, they would have had some kind of chemotherapy earlier again. 10% of the patients experienced grade 3, grade 4 events. 20% had neutropenia, which was grade 3 or grade 4, but none had febrile neutropenia. So this study concluded that this is in concordance with the Paloma study group. The second was presented in ASCO 2018. This is from Dr. Amit Rautansa's group. Here again, 133 patients on palbociclib between 2016 to 2019. Here again, exactly like the Flatiron study group, the median PFS and the overall survival wasn't reached, and there was no big difference when in the response rates and the survival when used in patients with bone only versus visceral metastasis. However, the neutropenia was significantly higher recorded in this, 75%, also thrombocytopenia, anemia. One point to note is 30% had dose delays and 8% had dose reduction. This is very, very important for us because many times we'll not be able to use that full 125 mg dose, and in view of continuing neutropenia, we might have to delay the next cycle. So overall, the study concluded that though there was higher chances of hematological toxicity, the results were very much similar to the Palomar trials. This study was done at Cancer Institute at DR. This was done by my friend himself. And this, however, was a smaller study group, a fewer number of patients. And this study actually showed that the survival was not as in Palomar. The median PFS was about 18 months only. And significant higher toxicity was seen in these patients. 24% required dose reduction because of fatigue, mucositis, neutropenia. So here we have a slightly lower survival in this group. This study is from Bhagwan Mahavir Jain Hospital, Jaipur. This is again concording with the study of the Palomar trial. So this is recent from 2020 ASCO, 102 patients, significantly higher response rates of about 17%. Most of them had stable disease, and safety-wise, about 39% had some amount of adverse events, most commonly being neutropenia. However, none had febrile neutropenia. So in short, palbociclib is, we are most experienced with this CDK4 inhibitors than the other two when it comes to using in patients with advanced metastatic breast cancer who are hormone positive and HER2 negative. Most of the studies do complement with the study from the Palomar trial group, and although there is no randomized comparative trial comparing the three CDK4 inhibitors individually, since we are very comfortable with the use of palbociclib, I think the way forward is with the use of palbociclib and letrozole or fulvestrant. I thank you for giving me this opportunity. Thank you, everyone.
I thank Dr. Vishwajit for that wonderful talk. It is one of, I think I can tell you, is one of the most important talk we had for this session, because that gives it is so much in close proximity to our practice, and it gives you so much of information to our daily practice. That was a very nice presentation. Next, I welcome Dr. Akhil Kapoor for the next session. This is a Lilly sponsored session on abemaciclib. When cancer doesn't take a day off, then why should a CDK4/6 inhibitor? Dr. Akhil, are you there?
Yeah. So the topic has already been announced by Srinivas sir. So these are my disclosures, and let's start. I will be brief. I will try to be on the point so that we can finish on time. So abemaciclib was a drug which was developed in the lab of Lilly Research Laboratory at Spain, and it was one of the 1200 drugs which was tested with main two endpoints. One was continuous dosing and blood-brain barrier penetration. So these two are most important differentiating characteristics among the various CDK4/6, because we have seen detailed sessions of abemaciclib and ribociclib. Don't have very good cranial penetration. Was discovered in 2008. The main criteria later, that what was the main point? Sustained inhibition, that is continuous inhibition of the drug, continuous inhibition of the CDK4/6 will lead to permanent cell cycle arrest and will lead to lack of proliferation and cell senescence. If there is short-term inhibition, there will be temporary cell cycle arrest, and it can lead to the restarting and rebound induction of DNA synthesis, which might be detrimental. So the abemaciclib has a small difference in the structure. With way this is different. If we see, it is ATP competitive CDK4/6, and if we see the ratio CDK6:4, it is 14 times. So definitely it is important to be noted that this has definitely a significant difference. What is the importance of CDK6? It is regulating the quiescent exit in human hematopoietic stem cell, and it's a transcriptional transregulator to suppress the ERGR1 hematopoietic stem cell. So CDK6 deficiency is characterized by defects in the hematopoietic system, and CDK6 is an important point which is noted as the activity of abemaciclib. Also, abemaciclib has some activity over CDK9, and CDK9, due to its activity on CDK9, there is some amount of diarrhea which was implicated in the randomized trials from the West. However, I would again like to highlight our patients, to my best of my experience, we have now experience of 25 plus patients. I have not seen grade 3, grade 4 diarrhea in my patients on abemaciclib. Let's see some data from the phase 1 study. Neutropenia was not dose-limiting toxicity, thus continuous dosing was feasible. However, in the case of other two CDK4/6 inhibitor, it is very clear with our experience as well. The rest two CDK4/6 cause significant amount of neutropenia, therefore leading to non-feasibility of continuous dosing. That makes life difficult for the physician. If we see the phase 1 trial, you can clearly see the patients, there was single agent activity in subgroup of even a single agent activity in heavily pretreated patients. And you can clearly see the neutropenia was not a dose limiting toxicity, and it was actually fatigue in the real world. If we see this intracranial models, we can clearly see the drug is very well getting distributed into the brain. You can clearly see this is a very important measure which we take into an account, especially in patients who are already having brain mets, but also some patients progress in brain. So that is important not only for patients who already have brain mets, but we know some of the patients who have significant disease burden can fail in brain. So that is one of the point which makes me somewhat selective towards utilizing this drug. And activity in the brain is demonstrated with this model. Let's share some real world experiences. Let's start with one of my patients with primary endocrine resistance. This is a lady which presented with, you can clearly see a 44-year lady who was premenopausal, having 2 children. Patient presented with pus and bleeding from left breast. She was PS1 with a large lump of around 7 by 6 centimeter in the left breast. And you can see this imaging, the PET scan at the baseline. You can clearly see there is a large breast lump, and also there was found to have metastatic retropectoral nodes at the baseline. The patient was ERPR strongly positive, 8/8 plus 0. Patient was KI 67-70%. This patient was treated with 4 cycles of EC as a new adjuvant treatment, dose dense EC. The patient didn't have good response. Then the patient underwent surgery, and the surgery showed YT4T4B lesion and N3A disease. The patient was planned for starting adjuvant paclitaxel followed by radiation and hormone therapy. The patient, after 2 cycles of adjuvant paclitaxel, there was a lesion recurrence at the suture site. And at that time, the imaging showed significant metastatic lesions in the lungs as well, also along with the local recurrence. So this was a primary chemotherapy, also refractory disease that was that doesn't happen very commonly, that patients has progression on the disease while on adjuvant treatment, but this happened in this patient. So this is clearly suggestive of very aggressive disease histology and extremely poor prognostic group. The patient was counseled accordingly. Patient was started on leuprolide letrozole initially. The patient didn't have any symptomatic benefit. There were some new lesions as well in the scans, bony lesions plus lesions in the lungs. The patient was now started on next line of treatment with fulvestrant along with abemaciclib with zoledronate. The patient had significant clinical benefit, and we will see the images in the upcoming slides. Let's see some data from Monarch 2 trial, which is overall survived by the endocrine therapy resistance. You can clearly see the primary endocrine therapy resistance, these patients are also having significant benefit, and the curve separating very, very well, and it is somewhat similar to the entire curve. If we see the Paloma 3 data for overall survival, you can again see the palbociclib plus fulvestrant is giving overall survival benefit. If we see no sensitivity to prior endocrine therapy, still the curves are separating. The patients with having prior endocrine therapy, the curves are still separating. So it is important to note, yes, there is some difference even in patients who are having primary endocrine resistance. And this curve, which helps us to understand with endocrine resistant population, yes, this is the data from ribociclib studies. Ribociclib is able to prolong overall survival, but this is possible only in endocrine sensitive population, and in endocrine resistant population, the curves are matching and not separating. So that is one of the difference which makes us understand, yes, there is some difference. This is the scan in this patient after 6 months of treatment. You can clearly see the scans, significant improvement in the both the breast lesions, and the patient had significant improvement in the lung lesions as well. So let's move to another case, patient with significant liver metastasis. Let's see, this is a young lady, 25 year, so young lady with no BRCA testing was done, it was negative. The patient has treated with dose dense AC, dose dense paclitaxel, then underwent BCS. Patient received adjuvant tamoxifen and radiation. It was baseline PT2 and 0 disease only, and germline BRCA was negative. The patient presented with the recurrence of the lesion after 3 months of the treatment. You can clearly see it was endocrine receptor, estrogen receptor was 8/8, PR was 4/8, and HER2 was 1. So on the scan, you can clearly see this is huge disease burden. You can clearly see the SCOUT scan. There are significant disease in the liver. This is clearly seeing the liver is significantly studded with mets. However, the patient did not have deranged liver function at this point of time. There was significant bone metastasis and other sites of disease as well. So liver and bone metastasis, ER/PR positive, ER was strongly positive, PR somewhat weak. Let's see the treatment which the patient received. Patient initially received palliative radiation to help the patient in overcoming the pain in the back, and also patient received zoledronate. If we see the data from this Monarch 2 trial, we need to understand patient with baseline liver metastasis, these are the curve is separating nicely, but even in the patients who are having liver metastasis at the baseline, you can clearly see the curve difference is significant. Though we are clearly understand the patient with visceral disease, that is liver metastasis, have in HER2 inherently poorer outcomes. For example, it was 12 months without liver mets, and the median PFS was going to 20 months. If we don't have liver mets, it was 3 months only without abemaciclib, and it's going to 12 months. So yes, patient with liver metastasis seeming to be having a significant benefit in terms of progression-free survival with use of abemaciclib. Similarly, there's data for Monarch 3 also, the similar data which suggests that yes, patients with even premenopausal ladies who receive non-NSAIs along with abemaciclib are getting significant benefit when the patient is having liver mets as well. So the patient, this patient was having reduced ejection fraction as well. This was implicated to prior adrenomycin-induced cardiac dysfunction, and the patient was started on abemaciclib with leuprolide and letrozole, and the patient had significant clinical benefit after 3 months. And you can see the images. Yes, the liver images, you can see this is extremely good response, and the patient had significant benefit. This image will help us to understand what is the difference in the images at around 6 months of the treatment. You can clearly see the liver has in now complete metabolic response. The bony lesions have also significantly disappeared. So that makes us very confident that the patients with extensive liver mets will also get a significant benefit with this drug, and that makes it very important. Let's come to a very routine case which we commonly see in our practice, patient with bone mets. Yes, MBC with endocrine receptor positive patients are known to have significant amount of bone mets only. Visceral mets may not be present in the patient at the baseline. Brain mets may not be present at the baseline. So this patient is a 51-year lady with who is a housewife and mother of 2 kids. 6 months history of right breast lesion. A PET CT showed multiple skeletal lesion. ERPR 7/4/0. And this is the imaging at the baseline. You can clearly see the lady has around 7 centimeters, 6.7 centimeter to be precise, mass in the upper quadrant of right breast. And there were multiple enlarged nodes, including internal mammary region. And there were multiple bony mets at the thoracic vertebra, which is a very common scenario in the breast cancer. Let's see the subgroup analysis from the MONARCH 2 and 3 data. There you can see patients who are having bone-only mets. The data, the curves are very well separating, and this is similar to the patients who don't have bone mets at the baseline, bone-only mets at the baseline. So yes, these patients seem to benefit in both in MONARCH 2 and MONARCH 3 data. And abemaciclib is not only for patients with high-risk disease burden. The patients with regular bone-only mets also tend to get significant benefit with the drug. And in our experience, that toxicity is also well tolerated. This is one of the difference from the Western data and our own experience. The patient received letrozole, abemaciclib plus zoledronate, significant clinical response at 3 months. This is the scan, significant decrease in the breast mass and internal mammary nodes, and there was also significant sclerosis in the lytic vertebrae at the thoracic vertebrae. And this is the recent image. Around 1 month back only, the patient has a very significant sustained maintained partial response. With this, I have presented 3 different case scenarios from my real practice, and I think we can take some comments from Dr. Srinivas, who is also an expert in this field and a very beloved senior from our own institute. So Dr. Srinivas, let's take your comments and let's have a small discussion if feasible.
Thanks, Akhil. It was a wonderful presentation. The one which you showed, the 3 typical cases, is the one which we see that in the day-to-day practices. And it gives you the imaging, what you showed, that 6 months interval, the response, the remarkable response. Such a, it's a very happening thing to see. And it gives you such a, that gives you such a clinical, the confidence to counsel the patient, it's something remarkable. See the image. It actually in case we can show this to the patient. In fact, this is how the drug will do you down the line 6 months, and this is something educative kind of thing. This is a very remarkable thing. I appreciate you for the presenting these wonderful cases. We'll quickly move on to a few questions. Ekta, can I just share my screen or something like that?
Yes, I have stopped sharing. You can go ahead.
Yes, sir, you can share.
Is it happening? Are you able to see my screen or something? Am I visible?
We can see the slides, but not in that mode.
1 second, I'm doing it. Is this fine now? Are you able to see?
No, sir. No, sir. We are not able to see your screen.
How come?
Just share it again.
1 second. Now?
Yeah, it's coming. Yes, sir.
This is fine now. Yes.
Just a second. Sorry for that.
Yeah. So go on slideshow mode. So your screen will be.
I'll do that.
Yeah.
Is that fine now?
Yes, sir.
So I can ask Dr. Vishwajit, are you there? Dr. Vishwajit, Dr. Bharat?
I'm here.
Dr. Bharat, I want you to join this session, please.
I am here.
So Dr. Akhil presented wonderful case scenarios in all the 3 different settings. These are my disclosures. Dr. Akhil, in ER positive, PR positive, HER2 negative MBC, what's your opinion on prediction of resistance, especially high mitotic aggressive tumor with regards to surrogates of luminal B, like high grade or negative PR or high K67?
Correct. So we know from our experience and the traditional teaching as well, luminal A does really well on endocrine treatment, while luminal B, it is a group to look at where we know the PFS will not be as high. We need to be very careful. We should monitor the patient closely. In usual times, we know that the patient is not going to progress very fast. We just keep on doing a chest X-ray and USG. We do not do usually even CT scans every 3 monthly, but it is a luminal B where we need to be very careful, and we know that the chances of having endocrine resistance is very high, and we need to be very careful. So I tend to take these patients with very careful examination, both local examination and also, if feasible, scans 3 monthly.
Dr. Bharat, your inputs?
As said by Dr. Akhil, he's right. They are clinically distinct subsets, and in follow-up, they're important. And we do get a sort of clue about, whether this is luminal A or luminal B based on the IHC4, based on ER-PR, especially PR negativity, high Ki67, and maybe a low ER or an intermediate ER. We get a sort of clue, and most of the time it is right also. And Ki67, especially if it is above 35 or above 40%, is a good diagnostic tool to predict luminal B subtypes. Between around 15 to 30, I think luminal the Ki67 is not a very good marker, but below 15 or below 10% and above 35%, it's a good marker to distinguish between A and B.
Absolutely, I would agree with you. So it's a heterogeneity in HR positive. We all know that. So distinctly, it's a spectrum, like towards a bad prognostic marker, luminal A versus luminal B, as you rightly said, high tumor grade, negative PR status, visceral disease, liver metastasis, shorter time to recurrence from early stage. I think we need to distinguish between these two and take a decision in the day-to-day clinic. So in view of your experience with all the 3 CDK4/6 inhibitors, could you shed some light on the patient's attributes or characteristics that make you choose Abima in your clinical practice? Dr. Akhil, you can take that.
Yeah. So definitely, I have shared my cases. One patient with having primary endocrine resistance, other patient with a significant visceral disease burden. One of the patient who was having liver mets, this patient was having low PR as well. Prostrogen, that is PR receptor status, was low. So it is a luminal B type. So these are some of the important points which I make me very careful, and I try to always incorporate these things in my mind. And also patient who was progressing very rapidly, having primary endocrine resistance. These are definitely patients who are going to do poorly. So I would always try to utilize this drug where we know there's a clear benefit over other drugs in terms of having better responses. So
Dr.
these
Bharat,
are the.
Dr. Bharat, you are the senior most guy. You have, I'm sure that you have used all those 3 available in the market. What's your take on that?
Actually, my experience with palbociclib is the most, then ribociclib, and abemaciclib slightly less. But as pointed out in his presentation, if there is a rare patient with a CNS involvement, I would definitely prefer abemaciclib. Primary endocrine resistance, if we see, especially in the adjuvant setting, we are seeing a fast progression, and we still want to use a endocrine therapy in that setting. I think abemaciclib is the right choice in that setting because it has got a more broader CDK inhibition than palbociclib and ribociclib. So I think the the more aggressive disease, biologically or clinical behavior, CNS disease, these are diseases that I think abemaciclib would have an edge. And of course, I think he pointed out abemaciclib does have some single agent activity also. So that also, if we have to use it, when in a patient whom we've used all the hormones, I think again that is an area which is very specific for abemaciclib.
That's absolutely right. So what's your treatment of choice in HR positive HER2 negative MBC with multiple visceral metastasis and symptomatic disease? Patient is not essentially in visceral crisis. Do you really opt for chemo, or still CDK4/6 would be the go, or endocrine therapy alone? Akhil?
Yeah, if CDK4/6 is affordable, I would always prefer CDK4/6 with endocrine therapy in these patients. It has been clearly specified the patient is not in visceral crisis. And definitely, in my experience, CDK4/6 is able to get the disease under control within 2 to 3 weeks of starting the treatment. So this is a very quick, it is somewhat very close to chemotherapy only, and without the usual chemotherapy side effects. So I would be happy to utilize CDK4/6 plus endocrine therapy, and this is the way.
Dr. Bharat, would you be doing the same thing?
Absolutely. And if you want a quicker response, definitely CDK4/6 with endocrine therapy. If the patient is not in visceral crisis, I don't think we would go for chemotherapy.
No, the notion was like when you want a quick response, then generally you tend to do a chemo, but that concept has gone. Now the studies have shown that
yes, I think that concept has gone. Now it is it would be a CDK4/6.
We all know that it can be as quick as any kind of chemotherapy. That you can get a quicker response when you add CDK4/6 inhibitor with any kind of endocrine therapy. Yes. The ancient guidelines about visceral crisis. I'm not going to bore you with all those things. We all know that what is visceral crisis, what we are supposed to do in visceral crisis. As you rightly said, probably only when there is an impending organ failure, probably that is a time when we really want to give some kind of cytotoxic agents to just get a very quick response. Otherwise, as you rightly said, CDK4/6 with endocrine therapy would be the choice. So what's your opinion on abemaciclib's unique continuous dosing schedule pertaining to implications in your clinical practice? Dr. Akhil, you can take this.
Yeah, so as I had highlighted in my presentation, so if there is continuous dosing, this is possible because this drug doesn't cause so much of neutropenia, which is very common with other two drugs. But the advantage is that due to continuous dosing schedule, the compliance of the patient becomes much better. So compliance is an important issue for our patients. Sometimes what happens, we explain 3 week on, 1 week off schedule, the patient forget to stop the drug, then the patient will have excessive toxicity. Sometimes the patient stopped the drug for a week, but then forgot to restart in the correct time. Then again, the efficacy will be compromised. This problem doesn't arise with abemaciclib. So this is definitely a significant amount of compliance benefit, apart from the usual benefit of having continuous dosing, the benefit understanding.
Bharat, your take?
I mean, I think I slightly differ on this point because compliance is generally not a problem for all the three inhibitors in the absence of toxicities. The toxicities that make compliance difficult. See, primarily, these are patients who are paying a lot of money for these drugs. Actually, they are more compliant. There are times when, if there is a 3 or 4 day delay in calling back the patient on ribociclib or palbociclib because of, something, we are out of station or whatever. The question is, can we do the blood counts and start, and see you after 3 days? So I do find, because when they're paying a lot of money, these patients are quite compliant with the drug, even when they go on to the free phase. But the forgetfulness, a daily drug is always more easy to remember rather than an on-off drug. That part is definitely true.
Yeah. I have a kind of challenges generally, 21 day on and off, 1 week off schedule. Generally, they come with a blood report when there's a neutropenia. They are not very sure. They are not very comfortable even with I'm talking about the other CDK4/6 inhibitors. The day when they want to come to show the CBC report, sometimes they don't come there. They end up in delaying for more than a week or 2 weeks sometimes. Actually, in that way, the complex issue actually becomes a challenge, rather than a daily dosing. And as Dr. Bharat alluded to, daily scheduling, daily taking is something it's like a unconditional or your subconscious thing, which is it just keeps going. Like a diabetic medication or a hypertensive medication, you're supposed to take in the morning. Just keep a reminder every day. They take it. The confusion starts when you off the therapy. So probably I think Abhima has an edge over other CDK4s as far as the scheduling is concerned. What are the toxicities you closely monitor for each of these CDK4/6 inhibitors in your practice, Dr. Akhil?
Yeah. So starting with palbociclib, we know that it causes significant of neutropenia. However, I completely agree, FN rates are not very high, but definitely neutropenia triggers some amount of stress in the patient's mind. The patients always try to see the reports. They point us to that the patient is he is having or she is having so less amount of counts. What should we do? So that remains an issue. Apart from this, fatigue is a common problem. So with ribociclib, QTC prolongation is an issue, but might not be so relevant. But if the patient is having drugs which are causing QTC prolongation in as an interaction, it might become an issue. Therefore, QTC requires checking. Apart from this, in abemaciclib, diarrhea is a very common problem which has been reported in the Western literature. But in my practice, abemaciclib doesn't cause so much of diarrhea. I have utilized the drug in more than 25 patients now, but I haven't seen any grade 3, grade 4 diarrhea till now. Grade 1 to diarrhea can happen, but a good amount of teaching and just explaining about the toxicities and what action to take at the first toxicity becomes important. Fatigue remains a problem with all the 3 drugs.
Dr. Bharat, did you come across any toxicity issues with these 3 CDK4/6?
No, actually, no. They're quite easy to use. With the ribociclib, as Dr. Akhil said, we don't see too many problems with QTC. But for the first 3 months, we definitely need a lot of intensive monitoring. That part, although we have not had a major issue, we can't, because it's there in the guideline, we have to monitor more closely. That part is definitely, we have to do it so that there is a sort of OP burden on that monitoring part. Otherwise, they're well tolerated.
Yeah, absolutely correct. I think we are now familiar with all the 3 drugs because we give them, we see them in the routine day-to-day practice. Now we know, we are familiar with the toxicities. We are, as Akhil told, most of the time it's grade 1 and grade 2 toxicities, not much of grade 3 toxicities, and we can easily manage them in OPDs. So in view of overall survival data available for Paloma-3 and Monalisa-3 and Monarch-2, how do you prefer to choose between these 3 CDK4/6 inhibitors in endocrine resistant HR positive or to negative MBC? Dr. Akhil?
Yeah, so definitely overall survival data is important. At the same time, we want to see the baseline comorbidities of the patients, what drug is affordable and suiting to the patients. These are definitely important for us. At the end, the drug which the patient is able to take becomes the most important. So these are the important takes. And definitely, as highlighted by Dr. Bharat as well, there are some important subsets where we know abemaciclib has an edge over other drugs. That makes important.
Dr. Bharat?
I think, Dr. Akhil has really covered everything. As of date, I'm not sure that, although the survival benefit seems to favor ribo and abema, especially in the first line setting over palbociclib, I don't think there is much of a difference between these drugs. They seem to be all the same. But over time, I think the differential inhibition of CDK4 and 6 between palbociclib and ribociclib. Similarly, the more pan CDK suppression of the abemaciclib, other than the 4/6, it has got other off-target inhibitions. I think that is going to make a difference over time. And maybe we will move more towards ribociclib and abemaciclib with time. That's what I feel. But as of now, I mean, it really cost is the only thing that matters. I hear that one of them will have a generic soon, and then once the generic comes, I think, you know, the cost will be the deciding factor, like everything else in India.
I totally agree with you. So thanks for the wonderful inputs from you both. With this, I would like to end this session. And I'm so sorry for Dr. Bharat. It's already, we are running late, 20-30 minutes late. I'll end this session now. I will stop my screen share as well. Now I welcome Dr. Bharat for next talk. Bharat, Doctor, over to you.
Thank you, Srinivas. It is wonderful to see you on the screen after many years. I missed you when you came to Coimbatore, but thank you for this invite. Srinivas has very lovingly given me two very difficult and very large topics, both to finish in 10 minutes. I will try to finish in 10 minutes. One is the role of PARP inhibitors in germline BRCA breast cancer patients. And the second is integrating immunotherapy and PARP inhibitors in patients with BRCA or PAL-B2 mutations. I'm sorry, the slide here. So we'll go through the role, the mechanisms, the PARP inhibitors in the setting of metastatic adjuvant and neoadjuvant and ongoing trials. BRCA, the BRCA1 and 2, the mechanism of action is during any cell division or cell cycle, there are single-stranded DNA breaks or double-stranded DNA breaks. And these breaks, the double-stranded DNA breaks, are repaired by the HR pathway. And what happens is the PARP inhibitor, the trap PARP, sits on the single-stranded breaks and cause another break, a second break. And because there is a second break, they do not heal. And patients with BRCA germline mutations are already sensitive for the first break. So the first break happens, and these first break are the reasons for the mutations which cause the cancer. Now, the second break actually makes the cell cycle stop completely and put the malignant cell into cell death. Now, there are 3 trials in the metastatic setting that we are aware of. The 3 drugs, the olaparib, the talazoparib, and the niraparib. Niraparib is not available for us. So let us look at the Olympiad and the mBRCA. The Olympiad used the olaparib and mBRCA used the talazoparib in the metastatic setting. And in the metastatic setting, it was evaluated against treatment of physician choice. And in both these studies, it's 2:1 randomization. And in both these studies, you can see a delta of around 3 months in the median PFS with a hazard ratio of 0.58 in the Olympiad and 0.54 in the mBRCA. So nearly similar results. There is a significant improvement in progression-free survival. There is a significant increase in the quality of life, but both these trials did not show overall survival benefit. And what about tolerance? The anemia seems to be the most difficult side effect that we see with this class of agent, and this seems to be higher with the talazoparib. Neutropenia and thrombocytopenia are also significant with both the agents and higher with talazoparib. Surprisingly, this trial had no incidence of MDS and AML. The Bravo trial is the other trial that looked at niraparib. Niraparib is not available in our country, and here the PFS in the niraparib arm was around 5 months versus 3.1. The delta is around 2 months again. And these are all trials that randomized to treatment of physician choice. The Brocade, on the other hand, had paclitaxel and carboplatin in the standard arm versus veliparib plus paclitaxel carboplatin in the trial arm. Now, this is very important to note because we always say that use of platinum is going to give us almost the same benefit as the use of PARP inhibitors. Now, this trial actually had platinum in the standard arm at a higher dose, that is AUC 6. So this trial actually, and weekly paclitaxel. Weekly paclitaxel is also supposed to be one of the best ways of delivering paclitaxel in these multiply treated patients. So even when the paclitaxel was delivered weekly, AUC6 of carboplatin was given, it still showed an improvement in the median PFS of by around 2 months in the veliparib arm. So at 24 months, the PFS was 34% versus 20% in the chemo alone arm. And PFS at 36 months was 26% versus 11 months. The hazard ratio was 0.7 and the p-value was significant. So addition of veliparib, again another drug that we do not have, to a carboplatin paclitaxel based chemotherapy showed improvement in the PFS. Now, what about the adjuvant setting? This trial is a trial that we've all gone through so many meetings in the last 2 years. The evaluation of olaparib after neoadjuvant chemotherapy surgery with or without radiation as indicated clinically, to a maintenance of olaparib 300 milligram twice a day for 1 year. And this trial was presented both at ASCO and SABCS, and the primary endpoint was invasive disease-free survival benefit. What about the results? The results show nearly a 3.5% delta between the arms of observation versus olaparib. The 4-year overall survival is around 3.4% different. And this trial actually had hazard ratio of 0.68 with a significant p-value of 0.009. So this trial was positive for its primary endpoint, and indeed now it is considered standard of care to offer olaparib to women with germline BRCA mutation. This trial initially randomized only triple negative patients. It is only after a protocol amendment that hormone positive HER2 negative patients who had germline BRCA were taken on. So the number of hormone positive patients in this trial is lower than the number of triple negative patients. And however, there is some benefit for the hormone receptor positive patients, not to the tune of triple negative patients, but they also benefit from PARP inhibitor in the adjuvant setting. In the neoadjuvant setting, these are all small trials, phase 2 trials. The NeoTala, as the name suggested, evaluated talazoparib in the neoadjuvant setting. And the endpoint, of course, was the PATH-CR rates. The PATH-CR rates by the independent review was 45.8% in the total population, and 49, nearly 50% in the intent to treat population. So 50% PATH-CR rates for a single agent talazoparib, although numbers are very, very small, numbers are just 61%, but the PATH-CR rates are still impressive. This is the other trial that looked at olaparib in the neoadjuvant setting, that is the JEPAR-OLA trial. And here again, we see this trial is also important because this trial had olaparib and followed by anthracycline chemotherapy, or a paclitaxel carboplatin followed by a anthracycline chemotherapy. So this also looks at carboplatin versus olaparib. That is the only change. So paclitaxel olaparib followed by anthracycline, or paclitaxel olaparib followed by anthracycline. And in this trial also, the PCR rates were higher by around 2% in the olaparib arm. So but the carboplatin also gives a good PATH-CR in this setting. Now, this trial is a phase 3 trial. This was published in the Lancet nearly 4 years ago, the Brightness trial. The Brightness trial used paclitaxel, carboplatin, and veliparib followed by anthracycline, or just paclitaxel and anthracycline followed by surgery, or paclitaxel, carboplatin, and anthracycline. So there were 3 arms. We must remember, even now, carboplatin in the neoadjuvant setting is not considered standard of care by everybody. However, this trial addressed that question also, and not surprisingly, the veliparib arm along with the carboplatin did well, but the paclitaxel carboplatin arm followed by the anthracycline arm, also did equally as good as the PARP inhibitor arm. So carboplatin plus paclitaxel followed by anthracycline with or without a PARP inhibitor like veliparib gives nearly the same amount of PAT-CRs in neoadjuvant setting in breast cancer. So as of 2022, olaparib is now approved for 1 year in the adjuvant setting. And there is a 3-year DFS delta of around 8.6% with olaparib. And survival advantage of around 3.8%. So PARP inhibitors are good options, targeted options for breast cancer patients who harbor germline BRCA1 and 2 mutations in the metastatic and definitely in the adjuvant setting. And in the neoadjuvant setting, they do influence and increase the PAT-CR rates. Now coming to integrating immunotherapy, what has happened for regarding immunotherapy in the last few years? Atezo came with a bang along with nab-paclitaxel in triple negative breast cancer. There was a PFS advantage, but OS advantage was not there. And finally, last year, Atezo was withdrawn, at least in the upfront setting. Pembro came with an accelerated approval, similar to Atezo in 2020. And Pembro was also evaluated in the neoadjuvant setting in triple negative breast cancer. And as of now, pembrolizumab has attained the status of FDA approval in the neoadjuvant setting because of PAT-CR rate difference of nearly 7.5%. Again, the question of whether we can achieve the same thing with carboplatin alone, like we saw in the veliparib trial, remains unanswered in this setting. Looking at trials in metastatic breast cancer, there are small trials which combine PARP inhibitors with pembrolizumab. Niraparib with pembrolizumab has been evaluated and shows in around 47 patients in first to third line and shows an overall response rate of 21% without any new safety signals. Similarly, niraparib, the median duration of response is not reached in this combination. Olaparib and durvalumab have been evaluated in the Mediola trial. It's a phase 1-2 basket study. And again, in germline BRCA positive patients, out of 34 enrolled patients, 30 were evaluable, and overall response rate is a good response rate of 63% in this heavily pre-treated population with no new safety signals. The median duration of response is around 9.2 months and median PFS is around 8.2 months with the use of olaparib and durvalumab in patients who have received around 3 lines of chemotherapy. The Javelin PARP evaluated talazoparib with avelumab in the same setting, unselected triple negative breast cancer patient, very small number of patients, 22 patients. Look at the waterfall plot. There seems to be good responses with an overall response rate of 18.1%. And in the DDR, that is the double-stranded DNA repair deficient patients, that is like the HRD patients also, there is a higher overall response rate of 30.4 without any safety signals. So current evidence actually does not support the use of a combination of a PARP inhibitor with the immune checkpoint inhibitor unless you're doing it on a clinical trial. We need to proceed on this combination from phase 2 to phase 3 cautiously. And the role of carboplatin itself, in the triple negative or the BRCA mutated patients still is a bit on shaky grounds. So with all this in mind, as of now, they are not standard of care. Dr. Hoprugo is enrolling a trial of pembrolizumab plus olaparib versus pembrolizumab plus chemotherapy in the first line. It's a phase 2, which will go on to, become a phase 3 trial. And the results of this are expected in another couple of years. Thank you very much. And I hope I stuck to my time. Thank you, Srinivas, very much.
It was a very excellent presentation, Dr. Bharat, sir. It was a very, though it is late, it was very interesting to know the topics, the details you gave. At the end, I would like to do a vote of thanks. I thank all the speakers, the panelists, the expert, the chairpersons, the attendees, one and all. Thanks for that wonderful participation. Without you, no meeting can be successful. We have around 50 participants on the show. I thank all the academic partners, Pfizer, Lilly, AstraZeneca, Roche, Novartis, Natco, Zydus, Glenmark, Dr. Reddy's, Merck, and Co-Diagnostics for their generous contribution. Without them, we couldn't do these kind of meetings. I thank one and all. Good night. Sorry for the delay. Sorry for the late. We are running short of time by 20-25 minutes. Thanks for bearing with us. I thank one and all. Tomorrow we have a day 2 session on lung cancer. I would request all the participants to come in huge numbers and make this meeting very successful. Thanks one and all. Good night. Thank you very much.
Thank you, everyone.
Good night. Good night.
Good night.